لا انت جيبهم بس. بسم الله بسم الله بسم الله بسم الله بسم الله الرحمن الرحيم. بسم الله بسم الله بسم الله بسم الله الرحمن الرحيم. بسم الله بسم الله تست. بسم الله بسم الله الرحمن الرحيم. بسم الله بسم الله الرحمن الرحيم. بسم الله بسم الله بسم الله الرحمن الرحيم. هنا خلاص. بسم الله تست quanto تست مايك. بسم الله تست. بسم الله تست مايك quanto. بسم الله الرحمن الرحيم. تست مايك quanto. بسم الله الرحمن الرحيم. ثواني يا جوجو بس ما عملناش ثواني بيظبط حاجه ثانيه وبعد كده نخش لايف. بسم الله تيست. خش لايف.
تستون شعبان.
ثواني بس.
شعبان
الصوت
الصوت مقطوع.
يعني انت سامعني بس الصوت مقطوع صح؟
شعبان بعد المايك عن بقك شويه،
حاجه شويه عم بقى.
ووطي الصوت من عندك شويه، الطالع اوت وطيه.
لا هذا سماعة سماعة هيدفون ده كده سامعني؟ ريب ريب صوت مكتوم.
سامعك بس الصوت مكتوب. ماشي
طب كده ريب
كده تمام.
كده تمام.
ايوه خليك على كده.
انا إيه القاعة كده شغالة عندي وعندك.
القاعة كده شغالة عندي وعندك.
الصوت هنا شغال في القاعة برضه.
يعني انت سامع نفسك في القاعة، سامع صوت.
زي الدكتور روجيه
انت
كان
انت سامعني كويس يا شعبان؟
معك كويس. الصوت عندي شغال هنا وهنا. رياب
سامعك يا كبير.
خلاص كده تمام.
الصوت كده تمام.
ماشي يا كبير.
شعبان احكي اي حاجه معانا.
احنا كده كده هنعمل تيست احنا الثلاثة مع بعض، جدة والرياض والدمام.
يعني طول
نصها كده.
حديثه معانا.
اخليها بجد بيغني.
مايك وطي. قال له خليه يطول حديثه يحكي
طول احكي شوية كتار.
عشان نشوف اذا عم بيقطش.
احكي معنا شوية كتار يا شعبان.
طمني عليك.
رجب الصوت عندكم مش منيح. رجاج
كويس.
الصوت عندكم مش منيح،
ازاي؟
مش عم نسمع مظبوط، في ايكو.
شعبان حبيبي،
سمعني.
بس فرجينا الميكسر اللي عندك، الهاي واللو قدام. طفي الهاي كله، طفيهم. في عندك شيء مكتوب عليه اتش اي،
اتش اي
في اتش اي، وطيهم كلهم. هيدول الهاي كلهم وطيهم حبيبي.
وين؟ فين الاتش اي؟ كده كده طيب.
كده انت سامعني كويس.
كده صوتك كويس، بس انت سمعنا كويس.
احنا بس تحس ان في نبر عندك الصوت، تحس ان
اذا الصوت من عندنا كاتم معناتها من عندكم من الميكسر. شوف الواصل اللي عندك شعبان وعدل فيهم، شوف ما واصلين.
شوف وصلة الاو اكس.
شوف وصلة الاو اكس وظبط عليها حبيبي.
من هنا. قريب كده سامعني طيب؟
انا
كده
سامعك
ممتاز
كويس، اهم
صوتك.
حاجة انت سامعني
ممتاز
كويس.
صوتك.
طب اتكلم كده كتير، احنا سامعني ما اتكلم
انا سامعك يا كبير تمام. ازيك وزي الحال؟ تمام.
حلوه دي تمام. ازاي
الدنيا
حالك؟
عندك؟
افتح
الامور
أي-
تمام. انا ما اتكلم معاك كتير اهو. الصوت عندك كده كويس ولا متقطع ولا في حاجه ولا واطي ولا مكتوم؟ الدنيا كده تمام. شعبان
سامعني؟
انا سامعك كويس.
طب الصوت عندك دلوقتي؟
صوتك عندي تمام. بصوتك انت. انا صوتي اللي قصدي صوتي اللي واصل لك.
انا صوتك حاسس ان في رن هنا، بيرن رن.
في رنة ازاي؟ الصوت عندي، يعني الصوت بتاعي طالع عندك عالي جدا.
طب انت مجرب المايك لبقك؟
انا بعيد المايك عن بوجه شعبان.
يبقى احنا معلين عندنا احنا بقى، الصوت عالي عندنا احنا كده.
انت معلي الصوت من عندك على الاخر.
لا مش على الاخر، على النص.
طب وطي شويه من عند المكسر الصوت اللي طالع بتاعي. صوت انا اللي طالع، وطيه.
اتكلم.
يا اخي وطي صوت انا اللي طالع.
اتكلم يا رجب كده.
كده انت كويس.
كده كويس، ايوه.
تمام كده خلاص، اظبط على كده وما تعليش تاني.
خلاص.
خلاص. هتكلم تاني شويه اكتر اهو.
اتكلم انت
صوتي
بس.
تمام، ما فيش اي مشكله، ما فيش لوبنج ولا في اي حاجه. ايه اللي حصل تاني؟
على المايك، جربت السماعه.
المايك. خلاص انت ما تعليش بقى الليفل، خلي الليفل كده بتاع صوت تاني، ما تعلوش تاني. ماشي. شعبان. شعبان.
طيب
شعبان.
خليك معايا يا رجب عشان اعمل لك حاجه ثانيه دقيقه. نشيل المايك الثاني بس ركبه.
هم؟ عند مين؟ ده هنا يا ابني. فاتحين الصوت هنا. لازم ب 5 ثواني. اه. لايف نوصل بعد ممكن 3 ثواني 5 ثواني 5 ثواني.
كده سمعنا يا رجب؟
سامعك، صوتك تمام عندي.
خلاص احنا شغلنا المايكين كده.
من الميكسر صح؟
الميكسر، ايوه.
الله ينور عليك، واحسن كده. الميكسر كده شغال هناك.
الكبير الباشا هنا.
ماشي.
ماشي يا كبير.
جد
يلا.
تمام. عملنا معاه رن على محمد علي.
ايوه. خليهم يبعبصوا بس في البتاع، في المايكات. يلا. قول لمحمد علي بقى يلعب في
لما
البتاع.
تقول ايه؟
خلي محمد علي، احمد علي.
محمد علي اكلمه.
مبارك. دخلنا الخطوط في بعضيها.
احمد مبارك.
قول له العب بقى عندك براحتك.
احمد مبارك. محمد علي دخل بالليله كده عشان الصوت بتاع الدمام تمام. كله تمام.
بسم الله. بسم الله الرحمن الرحيم. بسم الله. بسم الله الرحمن الرحيم.
كده كله تمام. على البركه. توكلنا على الله.
حبيبي حبيبي الله يخليك. ادينا رقم.
سامعني كده؟ شعبان.
سامعك يا رجب كده تمام.
قلت شويه احمد الفيديو شويه. كده تمام. قال لي مش وصل للاخر يعني. قال لي سنه. قال لي سنه. شعبان.
يا رجب سامعك.
وطي سنه.
يا رجب. يا رجب. يا رجب.
ايوه.
خلاص كده اوكي عندي.
خلاص كده تمام، محمد علي يخش ويبقى الدنيا كلها تمام.
ماشي. شايف احمد هو ما يظبط الكرينتو. بسم الله. رجب. برو. الو. برو.
بسم الله الرحمن الرحيم. بسم الله. بسم الله الرحمن الرحيم. علي. بسم الله. اخر كده. علي من ده. اول المصدر.
كده كويس.
كده كويس يا جوزيف.
رائع.
طب تمام.
كده رائع. انت سامعيننا كويس؟ انت سامعيننا كويس؟
سامعك كويس يا جوزيف. سامعك تمام.
اوكي، ونحن سامعينك تمام. خلاص.
ماشي يا غالي حبيبي.
شكرا شكرا لك.
تسلم يا غالي.
الله يعطيكم العافيه.
حبيبي الله يعافيك. ناخد ده على ده.
يا رجب.
ابو حلاوه.
الله ينور عليك يا فنان. الصوت تمام.
تمام يا ابو حلاوه. تمام.
سلمنا على البرو.
بسم الله الرحمن الرحيم. بسم الله.
الرحمن الرحيم. تيست مايك. بسم الله الرحمن الرحيم. تيست 1 2.
حلاوه. ابو حلاوه على التابلت.
بسم الله الرحمن الرحيم. تيست مايك. بسم الله. بسم الله الرحمن الرحيم. تيست مايك 1 2. بسم الله. تمام عندك يا رجب؟
تمام تمام.
بسم الله الرحمن الرحيم. بسم الله. سامعني؟
بسم الله.
صوت بعيد اهو. خلي بالك مش واخدينه من الكاميرا يا برو. احنا واخدين شغالين المكسر. مش من الكاميرا زي ما انت كنت واخدين. يلا سلام. لا الناس بتسأل الناس انا مش لسه حاجه. لم الكاس دي واحطها في السياره بتاعتي من ورا. لم الكابل.
بسم الله. بسم الله الرحمن الرحيم. بسم الله. محمد علي. شوف محمد علي.
محمد علي مش موجود خالص معانا يا رجب. رجب الصوت عندك تمام؟
الامور كلها تمام الحمد لله. والدنيا كويس.
بايظه؟
الدنيا تمام. بس مستنيين بس محمد علي.
محمد علي
خلي
بيعمل ايه؟
بالك من الكراتين يا ابو حلاوه. اهم
منور.
حاجه الكراتين يا ابو حلاوه. ها.
ابو علاء منور اهو. ابو حلاوه الناس اللي كاس. الناس الشنط ابو حلاوه مش عارف اللي كاس اللي جايبها. الرياض ولا يا رجل؟
بتقول ايه؟
الرياض مش مفتوحه ولا؟
انا بتكلم على البوديوم عادي بس المايكات عادي بس عايز اجرب البوديوم. كده.
جرب البوديوم عندك. احمد اللي يتحكم فيه. بس اصغر شويه من كده، اكبر من كده بشويه بسيط. ان هم بيحطهم تحت بعض. والرياض جده
لندن
وتحت بعضهم كلهم يخلي دي البرزنتيشن.
اوكي ما في برزنتيشن.
مش عارف البرزنتيشن هناك.
لا برزنتيشن لحالنا هنا. برزنتيشن بعد الساعه 4 لحالنا هنا في القاعه.
هو كلمه
لا برزنتيشن في بعد. ايه برزنتيشن بعد الساعه 4.
سيبك من البرزنتيشن
2 4 يا حي مع بعض.
مع بعضهم بس
الساعه برزنتيشن مع بعضنا هون بس الدمام ما خسنا بالرياض ما خسنا. ديميكس انا خلاص وصلت الكاميرا وصلت سوشي على ديميكس. يا خيي قصدك الانترنت يعني ايه وصل الزين وصل الانترنت عليك انترنت خلص ماشي. البينك تبعولك 46 49 الفندق حبيبي عنده وايرلس ما عندهم اوكي انت كم عندك الرياض صح؟ حطهم كلهم تحت بعض.
زوزو
سامعك.
حلو. الصورة اللي عندك تطلع على الشاشة ايش هي؟ صورتك ولا صورة ايش؟
لا الصورة كويسة. الصورة عندي أنا كويسة فول كويسة. اللي عندك هون تبعت الرياض كبرها شوي صغيرة.
خلاص كده كويس؟
كده كويس. حط لي اياهم كلهم تحت بعض لندن الكويت جدة أو أنت ظبطهم زي ما بدك تطلع كلهم لايف.
ماشي استنى بس حق جدة يخش ثانية واحدة.
أوكي هيك تصغرها شوي على يعني شو اسمه الويتس تبعولها تصغرها شوي الويتس ايوه بس هاي هي. اوكي ذاتس ات 100%.
كويس؟
احمد
كويس
هيك
كده؟
بتعقد هيك. انا هلا كمان ببعث لك صوره.
خلاص تمام تسلم.
هيك كويسه جدا. وحط لي اياهم كلهم بعد اذنك حطهم كلهم تحت بعض جده الكويت لندن.
اها
رح ابعث لك انا الحين كده كويس شعبان.
طيب تمام انا حطلع الان عشان اضبط اسمي واخش مرة ثانية. خليك معي ثواني.
انا معك رح ابعث لك صوره كيف طالع عندك.
بسم الله الرحمن الرحيم. بسم الله. تيست مايك 1 2.
انت جرب ايوه لا اساس على المال فك الكابل بالراحه وواتنا وجربوا عشان تاخد الناس كلها. روح ده شيل المايك.
انا عندي طويل يوصل لها يوصل لعندك.
فوق اهي هنا
وهذا بيوصل لعندك لهنا. حطه عندك كده كويس.
مش عايز ده يا باشا.
مش عايز ايه؟
هاي.
مين اللي بيتكلم ده؟
الو شعبان.
ايوه مين؟ محمد ولا احمد ولا مين؟
منور يا شعبان، منور.
منور يا كبير.
صليت الجمعه يا بيه؟ انت مسافر، احنا ما صليناش الجمعه
انا
بسبب
صليت.
صاحبك
انا صليت الصبح والظهر. دقيت خلاص. خدت الوقت.
الا الصلاه يا جماعه، الا الصلاه. يلا يا رجب قوم صلي، يلا قوم.
بس ما تجرمش السماعه يا احمد، الصوت عندك.
يلا أوكي. قوم صلي، هنروح نصلي. يلا مع السلامه.
يلا الله يستر عليك.
الله يسامحنا.
ماشي يا كبير.
بسم الله الرحمن الرحيم. بسم الله ونعم بالله. نيجي نصلي دلوقتي. بسم الله. تيست مايك 1 2. بسم الله.
رجب الصوره عندك زرقاء قوي يا رجب. احمد احمد مبارك.
يس برو.
رجب
يلا. ايوه
الصوره زرقاء عندك قوي يا رجب. خليه يظبط
زرقاء،
زرقاء.
ليلتك زرقاء. يلا
والله الليله زرقاء مطينه بطيء.
يا ابني يا ابني.
خلي رجب يحكي معايا.
افتح ايرس شويه. تلت اب، تلت داون.
خلي روجي يظبط لك رجب الوقت بالانس. ولا في عندكم مصور؟
تيست مايك.
يا رجب
ايوه.
خلي بالك بعد ساعه يجي زنه من عندك.
لو عايز تعلي الصوت علي الصوت من عندك انت بقى. ماشي.
ما اوكي عندي، بس في زنه ما تيجي عندك. وطي براحتك انت، ما عنديش مشكله، بس في زنه ما تيجي عندك.
كده تمام.
ايوه بس في الصوره ما تتاخر عن الكلام.
الصوره نظبطها بس لما نيجي، بس نروح نصلي ونيجي.
ها
يا سلام عليك يا جوزيف، لو معاك كنت مظبطني انت في واحده زي دي.
تيست مايك. جدة تيست.
محمد علي.
لا وين بدي امشي حبيبي؟ شعبان سامعني؟
لا هو انت منور الشاشة.
الصوت كيفه؟
الصوت تمام يا كبير. بس اعمل تست مع الرياض.
يا شعبان.
يا كبير.
تمام.
شعبان. شعبان كل حاجة عندك تمام؟
ان شاء الله كله تمام.
يلا يعطيكم العافية. بس على البريك خليكم معنا لحتى نظبط كل الميكسات ويقدروا يفوتوا معنا اني ديسك لعنا ونعمل لهم تستات ونجربهم كلهم. وجربوا خذوا البرزنتيشنز من الدكاتره اللي هونيك المسؤولين عن الايفنت، يعني مثلا بجده ياخذوهم مثلا من الاسلام. يقولوا بدنا البرزنتيشنز بدهم ينعرضوا بجده. وانت شعبان شوف الدكتور المسؤول عندك خذوا منه البرزنتيشنز ونزلوهم على
بس بظبط الوايت بالانس عندك يا برو. الصورة زرقاء.
ايه؟
الصورة زرقاء عندك.
ايه لسه يا برو، ما فيش حاجه، مش كده الاضاءه. كده الاضاءه حتكون عندنا اول ما يبلشوا يتكلموا.
خلاص ماشي. ويقول لك جوزيف ربع ساعة والبرزنتيشن يوصل.
مشي حال البوديوم عندك؟
كده اوكي. الصورة كده اوكي.
هيك حتكون اول ما يبلشوا يتكلموا. بس هيك انه داخلين العالم نحن عاملين عمود دم شوي.
اوكي.
اوكي.
انا الكاميرا عندي هتكون فاتحه لونجو كده يا دوبك اتحرك من هناك عشان جوزيف واللايف ستريمينج.
خليهم يظبطوا بس اللايف برودكاست ويظبطوا البرزنتيشن بحيث انه يسجلوها كلها، ما ينسوا يسجلوها كلها، اهم شيء تتسجل كلها.
اوكي. اكلم انا محمد علي خليه يخش حبيبي. زرقاء زي ما هي برو. ايوه شيل الزرق خالص. ده اللي عندك ده شيله خالص. طفيه يا برو.
بدها تظبيط وايت بالانس.
ازيك يا دكتور احمد؟
اهلا، ازيك شعبان؟ اخبارك ايه حبيبي؟
اه والله يا باشا.
منور
حبيبي يا كبير.
حبيبي، تسلم.
الله يخليك.
كده كل حاجه تمام عندنا.
كله تمام. بس لو البوديوم ينفع يتزحن الشاشه شويه.
ايه؟
البوديوم لو ينفع ينزاح عن الشاشه شويه، لان انا لو طلعت اشوف الصوره عندك
بس تيجي
حتى الصوره عندك متاخره. شو الصوره متتاخر عندك يا برو، خلي بالك. شايف؟
شعبان بلش يدخلوا الناس ها.
طب شوف الصوره عندي انا. طيب شوف الصوره لما بتحرك.
سامعك. علي صوتك شوي.
بقول لك شايف الصوره عندك على الشاشه. شوف لما بتحرك.
انا صورتك عندي مبينه صح.
بسم الله الرحمن الرحيم. بسم الله. بسم الله الرحمن الرحيم. شوف السماعات دي شغاله كام. بسم الله. بسم الله الرحمن الرحيم. بسم الله. لف بقى على شفت. الا تاخد الزاويه دي. ايوه بس. والثانيه كذلك الامر.
حاج شعبان.
الاي بي اللي اخده يا صاحبي
منار استاذ محمد.
100
حبيبي يا حاج.
159.
اخبارك ايه؟
اتحرك عندك يا محمد. ثبت. الصوره ما تقطع من عندكم النت ولا شو؟ الصوره ما تقف يا محمد عندكم.
ده نت.
طيب قول للاستاذ محمد شوف النت.
بيقول لك محمد علي استنى هيظبطها.
خلاص ماشي. ان صورتك بتقف على طول.
ابو حلاوه.
النت هنا وكا زين. ارجع تاني يا محمد. ظبط عندك وكده خلاص اوكي. كده قطعت يا محمد. قطع النت عندكم. مش معقول مفيش بعيد العيد السودان ولا نجلس هتاخد اللي بعيد لو في خدنا من حد غير ايام في المكان يعني بعيد كتير بالظبط هو نفس لان الدكتور يعدي من النت ميجا عنده كده في الخط. عشان جبت 30 ريال ولا لما جبت خفت على 20 ريال صح؟ عمل مثال عليها ليه؟ انا عارف هو فاهم يجي عليا ان انا اقول لك ايه الكلمه دي والله دي عندك حاجه فيه عيب عليا ان انا اقول لك صح.
কি সুন্দর গ্লাস গুলো শুদ্ধ চিতিয়া বাংলা মতো
بدك السكرين دوبليكيت ولا اكستند؟
خليها زي ما هي دوبليكيت.
دوبليكيت فوت على الباوربوينت والغي البرزنتر.
لا انا مش مشكله، خلينا اما نشوفه هنشوفه هيطلعها ازاي. انا الى الان ما جربت الحقيقه. عادي بنسخرك ما عندك اشكال. نعم يا عسل. صورتنا احنا مش طالعه عندهم؟ ازاي صورتنا مش طالعه عندهم؟ احنا طالعين اهو. يطلع فوق. هقول لك انا ثانيه. فايرول انت منزل 7272 لا ما بقفله بس بخلي 7272 ويندوز فايرول.
আর ব্রাউন স্প্রে লয়ে যাও।
يا احمد طفي المايك وانت ما تحكي يا احمد، صوتكم طالع كله هنا يا احمد. رياب رياب
ايوه سامعك.
انتوا فاتحين، انتوا ما تتكلموا جنب مايك ولا ما تتكلموا، صوتكم كله طالع هنا. قال لي مفتوح عنده كل انه عم يعمل زز.
لا التليفون كان بيرن منه احمد.
سلام يا احمد، قول له طفي التليفون يا عم احمد.
كده الصوت تمام؟
تمام.
خلاص سكروا الدنيا بقى لحد ما يبدا. خليكم لسه.
رياب
محمد علي عمل معاكم تيست.
محمد عمل تيست بس الصوره بتاعته مش طالعه عندنا، جده مش طالعه عندنا على الشاشه.
جد عمل تيست.
الو الو.
صوتك
تمام. رياض سامعني؟
والرياض اختفى.
تمام يا جيمي سامعك.
طيب
رياض
شايفنا؟ شايف صورتنا؟
شايف صورتك كده بس صغروها الجنب بتاعتنا يعني.
شايف صورتي عندك يا
بالنسبه للصوت كله تمام؟ جدة رياض دمام
يا باشا
الصوت كله تمام؟ شباب الصوت كله تمام؟
الصوت تمام، سامعني؟
لا
سامعك.
دلوقتي حاصله.
بس صورة
جيمي
ايوه ايوه راجل.
صوتك واصل عندك تمام؟
انت صورتك عندي تمام، والدمام صورتها تمام.
الصوت
والصوت
مين اللي متحكم في اللايف؟ مين اللي متحكم في اللايف؟ احمد ولا محمد علي؟
شعبان علي اهي.
احمد
اتكلم
يا
صورته
باشا.
تطلع ها.
أحمد.
لان احمد خلي الثلاثه جنب فوق بعضهم يا احمد يا مبارك.
خلي الثلاث شاشات جنب بعضيهم.
لان محمد مش طالع تحتينا احنا شاشتنا.
هيظبطهم لك الثلاثه جنب بعض. يا زوزو اعمل جاليري ريموت يا زوزو.
شوف جوزيف شوف الدكتور
يا زوزو
زوزو بيشرب دخان. نروح نشوفه ناو.
قولوا مش وقته خلاص عشان هنبدا.
والسيجاره يسيبها لمين؟
الناس موجوده بره ها. في حد جه عندكم؟
احنا عندنا الناس بتتغدى دلوقتي.
طيب خلاص يا محمد امسك دنيتك انت وخلي التست مع محمد علي. امسك دنيتك انت الرونن واست وظبط حالك.
انا شغال تمام خلاص. انا خدت انسرتاتي من بره.
خلاص ماشي يا كبير.
خلي احمد علي خلي احمد مبارك معايا يا راجل.
غيروا بطاريات للمايكات قبل ما نبدا ماشي.
اوكي.
كله غير البطاريات وخلاص بقى رباعيه كده ولا 10 دقايق.
رجب خليك معايا قول لي لاحمد مبارك جوزيف دقيقه ويكون معاك. خليك قاعد عشان يظبط كل حاجه بالمره عشان
لا ما
ثاني
تقلقش احمد مبارك معاك.
انت تخش فهموا كده عشان مش وقت لعب خالص دلوقتي.
ماشي ما تلعبش احمد مبارك. خدوهم هم راجعين خدوهم يا ابن الحلال. هم راجعين يحد اللوجو طالعين بره خالص. هو يحد اللوجو والله تاخذهم كلهم بس بكلمه ما بيرد. وانت معاك بكلمه ما بيرد. ماشي انت مش مشكله عادي روح بس ارجع برد علي. انت عادي خليك لحظه.
احمد جوزيف هنا اهو يا احمد.
خلي جعفر يرد على التليفون.
ما يرد على التليفون جعفر.
وخليه هو يتابع مع احمد ماشي.
تابع مع احمد. يا احمد فتح لك يا احمد مبارك. دكتور احمد.
جعفر رد على التليفون. جعفر
هو معاك اهو سامع.
جعفر الو.
رياض لايف كده
عشان انا مثلا
ديكرمو कहाँ है तुम किधर है
انا ركبت خلاص انا جاهز. عم صادق يا عسل.
شوف انا كيف برتبها يا جعفر ركز معايا على طول. حرك الماوس حرك الماوس روح عندها روح عندها نزل شاشه اللايف بدل ما بعد شويه نزلت شويه ها الماوس نزل صورة شوية. نزل شوية صورة. يعني ما كمان.
الواي فاي اللي بعته
تمام. قصدك صورة؟
بس عايز منك خيارات هذه بس وتدور للشاشه هذه وتدور فيها تطلع صوت. ما تقدر ولا جيب ماوس ثاني، جيب ماوس ثاني. دوزو لازم دوزو. خلاص انت اختيار جاليري فيو. شوف الجاليري فيو هذا كده جاي خلاص خلاص جاليري فيو خلاص. جاليري فيو خلاص. بعدين نغيره بعد ما يتكلموا مع بعض هيبدا واحد يشرح هذا يشرح او سبيكر فيو. ماشي؟ ها؟
عمال معروف تطفي المايك تبع البوديوم بعد اذنك. داير عم يعطي مثل ايكو، عم يعطي مثل بارازيت رجال. صوتك كده كويسه. اوكي، هاي مقسمه 3: رياض، جده، دمام.
تعال.
اوكي، انت هيك اوكي. هاي الدمام وتحت جده. هاي رياض.
يلا 5 دقائق. يلا تعال معي.
احمد، كده انت فاتح 3. حدا يطفي المايك تبع البوديوم. عم يعطي احمد، سامعني؟ دمام، رياض. ايه عمار، في البوديوم بعد اذنك. اوكي، شكرا دكتور احمد محمد. اوكي، سمعوني كويس الحين من دمام رياض. هاي جدة. هاي جيمي هناك؟ ايه؟ مين هناك؟ مين بيقدر؟ الباسو تبعنا حب قلبي.
يا حبيبي وين الباسورد؟ باسورد اللي جاي معاك من الرياض صح؟
ليه بدك باسو؟ خلاص ما هون دغري عليه. لا 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 بلا باسو بلا باسو.
لا
ما ياخذ يا حبيبي ما ياخذ واي فاي عليه هو يا حبيبي بيشبك.
نتورك؟
ايه اعطيني كابل صغير نتورك. كابل صغير بس.
بس خلي بالك عندك.
باسورد بيكون تحت. ايه اي كابل اي كابل صغير ايه ازرق اسود اي واحد. دمام رياض سامعينك؟
ده فيديو البورتريه عم
واحد هذا كويس. اوكي وين الراوتر حبيبي؟ ترجع راسك وترجع راسك. صدق شيء عندك انترنت خلاص صار عندك.
باشا بص كده شوف بيقلب.
الله رحمكم الله يا قائد. ان شاء الله يكون في عليه انت.
وانت ما تحطش لو هنا حطيته جنب السماعه يكون في النص. لو واحد شاور بصوا لبعضيكم مش هاجي احنا مش نمشي احنا الاثنين.
بص مش هتنور.
بسرعه بس كام لقطه ورا بعض. لا لا صور صور. لا لا قرب يا شباب. خدت صوره ولا لسه؟ كذا صوره ورا بعض يا شباب. قرب مني بقى. مم.
ما في استغلت حب. دخل شعبان.
برو.
ايوه حبيبي، سامعني كويس؟
سامعك تمام.
محمد جدة، سامعني؟
بس في صورة بعتها الراديو بشوفها على الواتساب.
بس عم شوف جدة إذا عم يسمعوني. جدة شوف لي إياهم. جدة
جدة تمام.
جدة سامعني؟
تمام.
حبيبي الرياض كبيرة، صورتنا احنا فوق، صورة الدمام بتاع جدة تحتينا. أول مرة نشتغل. طب الدمام مش طالع.
شعبان صوتك على الهواء. جدة سامعني شباب؟
صوتك تمام.
اوكي جدة سامعيني كويس؟
ممتاز. يعطيك
اوكي
العافية.
يلا بس هنعمل تيست مع الدكتور وخلاص. اوكي
اوكي.
يلا.
خلاص المفروض الثلاثة يجوا في كده، احنا أربعة عندنا، أربع شاشات عندنا.
هاي دكتور.
طيب لو فتح
اسلام.
لو فتح الشاشة الكبيرة مش هتبان عندنا
اسلام اذا الدكتور مش حاطط ايربيس خليه يحط ايربيس بدينيه.
اديني أحمد أفهم.
Doctor, can you hear us, please? Good morning, doctor.
حبيبي احنا كده خمسة، اللي باين عندي أنا جوه على الشاشة هنا أول ما يطلع الدكتور بتاع رمضان شاشة كاملة، المفروض الثلاثة التانيين يبانوا في الجنب، صح؟ اديني يا أحمد.
اسلام. قولي مع اسلام خليه يحكي مع الدكتور، خليه يحط ايربيس. ويحط ايربيس، يحط ايربيس بدينيه. هاي دكتور اسلام. اسلام معنا؟
ايوه حبيبي.
حبيبي ازيك؟ بس
الحمد لله.
خليه الاي تي اللي عند الدكتور يحط له هيدسيت او ايربيس بدينيه ونسمع صوته.
هو الفيديو شغال بس الصوت مش شغال صح؟ اوكي.
فيديو شغال ما عندناش مشكله بس ما فيش.
اوكي طيب يلا هكلمه دلوقتي. Yes, Jonathan. 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 Better to use the headset. You hear me, Jonathan? Hello, Jonathan.
انا فاتح الجهاز قدامي يعني.
Jonathan.
Hello.
Jonathan, you can hear me?
Hello.
Yes, Jonathan.
Can you hear us?
Yes, I can hear you now, but the video disconnected. Yeah.
Can you see us now?
Yes, I can see you, and the video also is clear. You both look like stars in the video here.
Hi.
Hi, Professor. How are you?
Very good, thank you. And how are you?
I'm fine. I'm fine. Here, all the people eager and very ready to listen to your presentation. Roger, the voice clear here in Riyadh and Dammam?
Right. Excellent.
It's good. The voice is good, but we still need to put for him any maybe.
They are using Fujitech camera and headset and the mic together in the system
Yes.
in the at the office, Roger.
Yes.
It's a system
That's
of Fujitech. Fujitech speaker and the camera together connected to the laptop from the office, yeah, Roger.
Okay, خلاص, perfect.
That's right, isn't it? Is that Fujitech? This is Logitech, yeah. Logitech. Can you see my screen?
Yes, we can see now the presentation.
Okay, perfect.
Okay.
Okay.
We need to hear the voice for the doctor when he sits, please, for 2 seconds.
Yeah. Yeah, let me do a voice test.
Thank you.
So is the background all right in terms of behind me, or is it distracting?
I think it's okay. Background is okay. Roger, do you have any comments for the background of the video?
As long as you're happy that side, that's good.
Yeah,
We can
it's
move.
good.
You can move the camera a bit if you like. Would you like it closer or further?
No, the background is good. The background is good, and this face is very clear for us.
Okay, perfect.
Okay,
So I'll control the slides from here.
Yeah, the slides are now forward. Yeah, everything is clear for us. Yes.
Okay.
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 Dammam. دمام. جدة سامعني؟
سامعك يا برو، سامعك.
اوكي شعبان، ممتاز. ده جدة.
We can hear you.
تمام.
جدة، بعتقد جدة بس. متأكد من جدة بيسمعونا صح.
So I remove the. I can take it out. Okay.
سامعني؟
So which one is which one are you sharing first? This one or the previous one? Oh no, this is the second one. This is the second one. Yeah. Just want to make that clear. That's the first one. I just want to check something whether it has got a statement. Oh, sorry, that's the wrong one. We could, should we? So how are we going to transition between when we get?
شغل من عندك يا برو. في زرار من ورا. البوديوم مش شغال، انت دوس على
سامعني؟
سامعك.
انتوا الوايت بالانس عندكم كويس. تمام وايت بالانس ممتاز.
شغل
اوكي
المايك بتاع
وايت
البوديوم من
بالانس صار عندك اوكي. بعد في عندنا جدة ما مش عم نشوف.
روجيه
ايه حبيبي معك شريك.
سامعني؟
ايه دكتور معك.
تمام.
خلي بالك انا هنقول الكاميرا عشان يبقى في وقت لا نقولها هناك. كيف اخد وشك؟ لا نقول من ناحيه. مش هيطلع. لا احنا عندنا احنا مالكش دعوه بينا. عندنا احنا مالناش دعوه. هنا هيطلع البرزنتيشن. انت شوف الفيديو عامل كيف. بس عشان تطلع معلش عايز تكون الدكتور احنا ما عندناش هنا. بس احنا عشان نطلع من فيديو زي ده منظر مش اللي هو تشوف الفيديو في الرياض عامل كيف يا دوبك هنا بتاع القاع مش موجود اللي هو ما عندهمش اي فيديو ما عندهمش اي فيديو ثاني. المنظر مش حلو تحت.
جدة اوكي. رياض جدة تيست. جدة
جدة جدة
أيوة.
معك رياض حبيبي كويس.
تمام.
ضبط بس وايت بالانس عندك.
اوكي.
Hi, can you guys still hear us?
محمد اي واحد يسال يعني اوبننج عندهم الرياضيين.
جدة وايت بالانس بليز. وافتح فول لايت، بس يبلش البرزنتيشن تعملها دم. $3200. اوكي فوكس كده. افتح ايرس، فول ايرس، افتح فول ايرس. لا خفف شوي بس. اوكي اتس فاين.
ده قانون عندنا يسأل قدام البوديوم. عشان ما حد بدأ يقعد على الطاولة يقعد يسأل، لا ما
خليهم يحكوا، نحن كمان نفس الشيء. اي واحد بده يسال في صادق على الكاميرا.
اتكلم ده.
صح ايرس.
حركت بقى.
ونحن حتى عندنا اي وقت بس تبلش البرزنتيشن تحضروا مع الناس كل الوقت. طن يمين طن يسار، عادي هو شوفهم.
Hi, can everyone hear us?
Yes, we can hear you, doctor.
Okay, thank you.
We have to say thank you for you.
Can you give us small brief like about you, just to hear your voice very good in our country?
Hello, good morning. I hope everything is good there for all of you in Daman, Riyadh, and Jeddah. I look forward to talking with you in just a few moments. Is that sounding all right? Is that
Okay.
loud enough? Does it need to be louder? I can speak louder.
No, the sound is very good.
Okay, excellent.
Thank you, doctor.
I'll mute us just for the moment. Can you hear, there's an air conditioner here. Can you hear that noise?
دمام جدة، دمام جدة.
طيب
اوكي.
خش طيب خش طيب بعد.
دمام جدة.
Thank you.
يس. جدة اوكي.
في الدعاية تبع الأوتيل بجدة ما بدهم يشوفوها. إذا فيك تعلي الكاميرا شي تقريبا شي 10 سم فوق ال.
ايه اوكي اوكي.
استاذ محمد جمال.
يا صادق شوي.
محمد جمال. محمد جمال.
على قد الهدروم صح. يلا
محمد جمال.
ايوه سامعك.
الغي لي البوديوم خلص يا محمد. خش زوم ان.
علي صوتك.
زيح البوديوم شويه، زيح البوديوم وزيح كادرك شوي عشان بدون ما يبين حرف الباب.
روح روح روح
طلع وراك، طلع وراك.
يسارك. فين يسارك؟ روح يسارك كمان بالبوديوم ايوه شدوا عليك، ايوه دف عليك، دف كمان
بعد زيحه. بعد اكثر جمال. بعد
لحظة
وضيق شويه بالزوم تبعك. جمال
برو انا
منيح البوديوم شوية بحيث
كاميرا
انه
تاني
الزاوية تبعية الباب ما تبينش لانه بشعة.
يا برو، طلبوا مني اغير مكان الكاميرا تاني.
هذا الحرف تبع الغين تبع البيت. محمد جمال محمد جمال محمد جمال عقيل اسلام عقيل اسلام عليه خلاص خلاص اصلا كنت يا برو زي الدمام، نحن الدمام البوديوم يا اسلام اسمعني شوي لو سمحت. مع الدكتور و هطلع معه.
Doctor, doctor, stand by, please, because we're gonna be live in a few seconds. Thank you very much. Gedda, Riyadh, please. Dammam, are you ready, guys? In a few seconds, we're gonna be live. Thank you, guys.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm very pleased and honored to be with you today at the second national and first GCC Respiratory Summit. This is a simultaneous program running parallel in Riyadh, Jeddah, and Al Khubar. And we are very pleased to have distinguished speakers today and tomorrow. We'll be talking about asthma, the pathogenesis, role of biological agent, when to refer, and how to evaluate such cases, and in particular severe asthma among adult as well as pediatrics. Regarding the CME hours, it will be distributed around 5 o'clock today, but please make sure that you will sign again tomorrow at the end of the scientific program. So please make sure that your signature is there, otherwise you will not receive your CME hours. I'd like to thank the Saudi Thoracic Society members for actively participating in this event, whether speakers or a physician attending this event. Also, the Ministry of Health for their interest as well as keen in improving their knowledge toward treating asthma at all levels. In addition, I'd like to thank AstraZeneca for sponsoring this event. I would like to take this opportunity to announce that the launch of the Saudi Thoracic Society website after a long marathon of hard work and dedication of all members. Please visit the website and you can get all the details from the admin from the Saudi Thoracic Society. They're sitting in the back. Also, you can, also the new site that also allow you to be enrolled into Saudi Thoracic as well as the European Respiratory Journal and be a member online, which is make your life much easier. The first two lectures will be presented by Professor Bateman. He will be talking about the asthma and back-to-back. So, and we'll leave the questions at the end of his second lecture. At the end, I would like to thank all of you. Professor Bateman, the podium is yours. You can start now. Thank you.
Well, good afternoon, and thank you. It's a great honor to be invited to take part in this summit, and I'm glad to be able to join you, even though I'm a long distance away. I'd like to congratulate you on the arrangements made for this and for your attendance. So I've been asked to speak about asthma attacks, and in my first talk, I'm going to be talking about pathogenesis and therapeutic implications. And then in my second, I'll be focusing on the role or the significance of the reliever that we use in asthma management. So to begin with, a graphic always helps, reminding us of what happens during an acute exacerbation or acute asthma attack. This was a bronchogram taken performed in a patient with asthma quite unwisely, and it invoked immediate bronchospasm, and you can see the dramatic attenuation of all the bronchi with almost disastrous consequences. And this is really what we're talking about. But we need to start by asking ourselves, are we using the right term when we use the word exacerbation? It doesn't mean much to patients. And Mark Fitzgerald a few years ago wrote this editorial saying it's about time we need to talk about lung attacks. It's about time we targeted them because we are underselling as thoracic physicians the significance of these events. And so I want to talk about that a little bit more. In the Lancet Commission published last year, one of the main points, the main summary points of the Commission was we should have zero tolerance for attacks, and we should replace this inadequate term, exacerbation, and flare up with the word attack. And there was a recent publication from Australia in which they spoke to patients and said, well, what do these terms evoke in you? And the public at large would view an attack as something frightening, a frightening event. Whereas exacerbation and flare-ups, they could be mild or severe, they could be transient, and really their significance is very personal. So I think we need to think about the terminology of attacks. And I thought I'd talk about attacks under the following points. Their commonness, the cause and pathogenesis, the consequences, the clinical approach and prediction of risk of exacerbations, limitations of control-based treatment strategy, and then the challenge of early intervention for worsening asthma. So at population level, this is one of the most reliable bits of data coming from almost 500,000 patients with asthma in the United Kingdom, which gives an age breakdown of who gets asthma attacks and how many do they get. And you can see the age groups indicated in these columns. And patients who are having 2 or more exacerbations, you can see they're mainly children and older people, but of course all ages have these. And a significant proportion of patients have more than 1 attack in a year. And so in different age groups, you can see the frequency of attacks there. But one of the important conclusions there was that 60%, that is the greater burden of asthma attacks, is in patients who were considered by their GPs to be mild. And so we're not talking about attacks being in severe asthma. We're actually talking about the life of patients who we consider to have mild asthma. Now, this little cartoon shows the causes, the common causes of asthma exacerbation, or the factors that contribute, and I'm not going to talk about all of them, but I would point out that viruses are probably the most important and a significant trigger factor for exacerbations. And so we need to take this into account when we start to think about therapies, because we need to consider the viral axis that is responsible for 80 to 85% of exacerbations in pediatrics and a little lower percentage in adults. Any respiratory pathogen can cause it. Rhinoviruses are the most important. And of course, there's a seasonal pattern to this, with about 3 times more attacks in winter, that's in the more temperate climates, than in the summer months. And this interaction between virus and allergy is attracting more and more attention. We have some very good emerging basic science on this interaction. This slide comes from work done in West Australia, showing the relationship between risk of exacerbations and allergic sensitization alone, the presence of a rhinovirus, and when these are present together, and particularly if they have active allergic disease. And you can see the magnification, the potentiation of allergy with a virus, which makes it such a lethal combination. And we're starting to understand the mechanisms for that. But before I get to that, this is also a very familiar slide reminding us that exacerbations don't start instantaneously. They build up over the course of days. There's a warning period when the symptoms day and night start to increase, beta agonist use increases, and of course lung function declines. And the offset from the peak values are also quite evident here. If one follows the profile of symptoms and compares it with I beg your pardon, the development of nitric oxide, the release of nitric oxide that's shown in this graph in those colored lines, it can be seen that for days before the maximum symptoms are present, there is an increase in exhaled nitric oxide This study was performed in children. So it reminds us that not only do the symptoms go and the lung function and beta agonist use increase over days, but there's signs of inflammatory mediators increasing over that same period, which signals to us that inflammation is heightened during that critical phase in the development of an attack. Excuse me. So it has been shown that viral exacerbations are associated with an increase in sputum eosinophils. Occasionally, neutrophils may also be increased. And there are studies showing that as one withdraws ICS in patients with asthma, there can be an increase in sputum eosinophils and evidence for the release of eosinophilic granules. So exacerbations are tightly bound to the presence of inflammatory events in the lower airways. Now, what has also become clear in recent years is that there are consequences of an asthma attack. Too many clinicians think, well, it's just a temporary inconvenience. It's just something that is a nuisance, but it has no long-term effect. Well, of course, the evidence does not bear that out. In one of the early studies about the effect of exacerbations on lung function decline was this study from a single center in the Netherlands, showing that looking at patients over 30 or 40 years, the lung function decline was evident in patients who had more frequent exacerbations. And the important point here that it wasn't a lot of exacerbations that determined the lung function decline, but it was evident in those having only 0.1 of an exacerbation per year. So what we were considered low-risk patients were the very patients in whom lung function decline occurred. Excuse me. In one of the few longitudinal studies we have in early onset asthma is, of course, the START study. And here, what was being tested was lung function decline over 3 years and the effect of adding budesonide in half the population. And what you can see from this slide is that FEV1 decline in placebo group occurred, but if the patients were placed on budesonide, that lung function decline was reduced. But the important point here was that even one severe asthma-related episode, that is the red bars, was associated with a greater lung function decline in both the treated and the control groups. So that's direct evidence that exacerbations are associated with lung function decline. In another longitudinal study, this time from the CAMP study done in children, who were followed in this case till the mean age of 21 years, different patterns of growth and of deterioration of lung function were examined. And I put on and you can see there were 4 patterns there: normal growth and normal decline, normal growth with early decline, and then these 2 groups where there was faulty growth, but then also some of those patients, about a quarter of them, had reduced growth and early decline. And the risk factors for decline were shown there. The strongest was the number of oral corticosteroid courses. In other words, severe uncontrolled asthma is associated with long-term consequences. And this factor came out more strongly than any of the other predictive factors in this longitudinal analysis. And so the concept which Steve Holgate mentioned many years ago was that one of the distinguishing factors of severe asthma are first of all, the frequency of exacerbations and accelerated lung function decline. They go together, whatever the precipitating factors might be. Well, if we're going to get on top of asthma attacks, can we predict patients who are at risk? Because after all, in any 1-year period, some will have attacks, but some may have none. And the approach, of course, of prediction is that can we, by controlling asthma well, better in these patients, prevent the future risk of lung function loss, exacerbations, and exacerbations. Well, this approach of what we call control-based reduction of exacerbations was really the theme of the 2006 GINA document, which followed on the GOAL study. And you remember on the GOAL study, we tried to achieve optimal asthma symptom control in order to prevent the risk of exacerbations. And this slide, which was published, the work published this year, we analyzed the frequency of exacerbation, in other words, the risk of exacerbations in patients who were uncontrolled versus those that were controlled. And you can see that patients who were well controlled had a much lower exacerbation risk than those who were uncontrolled. So the hypothesis is correct. The better current asthma control we achieve, the lower the risk of an exacerbation. So that's a good start to our approach. But I need to point out that even the patients in the well-controlled group, their annual mean exacerbation rate was 0.1. Now you'll know from the Dutch study I mentioned that 0.1 was sufficient to be associated with lung function decline. So we cannot ever say that a patient who's well controlled is free of risk, nor can we say that they're free of risk of lung function decline. So the GINA assessment tool, which is well known, of course, reminds us that to assess control, we look at daytime and nighttime symptoms, reliever use, and activity limitation. And since the 2006 report, there have been many different control measures developed that we should be using to assess symptom control. So when we look at our treatment here, we ask, well, what is our approach to exacerbation reduction? What are the treatment options? Well, we rely for exacerbation, for control of symptoms and exacerbation reduction, the controllers. At step 2, we have 2 options, low dose ICS or daily leukotriene receptor antagonists. We have medium dose ICS or combination or combinations with LABA or leukotriene receptor antagonists. At step 4, we can add tiotropium, and then of course at step 5 we'll be talking about biologicals. Now, sadly, we need all of these treatments have variable ability to achieve control. And around the world, and Saudi Arabia is no exception, how are we doing with all these options that we see within the GINA treatment steps? Well, I was interested in the ESMA study results from Saudi, which showed that about 1/3 of patients have good control, about 31% are partly controlled, and about 1/3 are uncontrolled. So I guess we would agree that this reflects probably what is present in many different countries of the world, and that there's a lot of room for improvement. Because remember, if patients, about 1/3 of our patients therefore have reduced risk, but the other 2/3 remain at significant risk of exacerbations. So the control-based approach to reducing exacerbations is good, but it's not infallible and it's not sufficient. I like to show this slide from the GOAL study, which reminds us that although we got good levels of control in patients with maximum doses of fluticasone and salmeterol, that's the purple lines, or with high dose fluticasone alone in different strata, although we achieved good control in many patients, there were many days where patients remained symptomatic. Overall, if they were only on steroids, on 45% of days, that means every second day they needed a reliever for symptoms. And if they were on maximum doses of serotype, there was still 1 day in 4 where they needed a reliever. So symptom control is not complete in patients, even who are achieving good levels of asthma control. this has led to the suggestion, and this comes out in the GINA 2014, that we mustn't simply rely on good asthma control, but we need to consider risk separately in every patient, and we need to think of treatments in terms of their ability to target risk or reduce risk. So what I'm going to talk about is what treatments do we have, what prediction can we make about exacerbations, and what treatments do we have. I believe this is a very important box in the GINA document, which shows the modifiable risk factors of exacerbations. And I like to remind people and myself that for every patient in every consultation, we should be asking, does my patient have any of these risk factors, which puts them at greater risk of an exacerbation? And because having uncontrolled asthma symptoms is an important risk factor for exacerbations, and having any of these increases their exacerbation risk, even if they have few asthma symptoms. So here's a list of the factors in that table. I've blown them up for you to see. Some of the reasons are obvious. Inadequate inhaled steroids, poor adherence and inhaler technique, a low lung function, smoking, pregnancy, and of course, sputum and blood eosinophils and an elevated FeNO. These are all risk factors, and I'll talk about them for just a while. But one of the major reasons for severe attacks, and particularly life-threatening attacks, is SABA overuse. That was the first point on this list of modifiable risk factors, patients who are using too much SABAs. And in this analysis, which you've all seen, I'm sure, from the Royal College of Physicians, this table shows, this figure shows the very large numbers of prescriptions of SABA in the year before the patient died. And you can see there are many patients who had 10 or more inhalers over the last, in the last year before they died. SABA overuse is a significant risk factor for exacerbations. And again, as we'll talk about soon, about 50% of deaths were in patients who were thought to have mild asthma or moderate asthma. In fact, over 50% had mild or moderate asthma. So again, risk of attacks, risk of deaths occurs in patients overusing SABA who are thought to have only minor exacerbation risk. And in fact, more formal studies like this one from the USA shows the relationship between the numbers of SABA canisters prescribed per year and risk of hospitalizations and of oral corticosteroid prescriptions. And you can see a very clear relationship. The more SABA canisters used, the greater the risk of not only death, but hospitalizations and oral steroids. And this is a different study also from the USA, showing again the same factor, more than 3 canisters per year increased the risk of hospitalizations and emergency room visits. And in the UK, back to the assessment of asthma deaths, the 2 most important reasons for asthma deaths in analysis done in 2014 is undertreatment with inhaled steroids and heavy and increased use of beta agonists. So that is a real risk factor. Of course, the second most common risk factor is an exacerbation in the past year. And this analysis from the USA showed that regardless of how the risks were analyzed, whether by severity or asthma control or physician-assessed severity, the risk exacerbation of the previous exacerbation was the most important indicator of future risk. So a patient who's had an exacerbation in the last year is at risk of more. What about low lung function? Physicians often ask me, how important is lung function in asthma? Well, it is a prediction factor and quite a reliable prediction factor for increasing risk of exacerbation. This slide shows 2 studies, one from Netherlands and one from the United States, showing that as FEV1 decreases, the risk of an exacerbation in the next 3 years increases. But it's important to notice it only starts once the patients fall below 80% of predicted. So if patients have normal, a normal lung function, it doesn't really help to keep on doing lung function to assess risk. But in the patient with severe asthma, with lung function below 80, the lower the lung function, the greater the risk of exacerbation. Here's a more recent study looking at risk factors for more than 2 exacerbations per year. And here the most important predictive factors were eosinophils in the blood, greater than 400 versus less than 400, any asthma exacerbation, and also the older patients. So these were the risk factors. What about inflammatory markers? This study from the NHANES studies shows us the relationship between blood eosinophils, FeNO, and risk of asthma, either asthma attack or an emergency department visit. And you can see that from the stacked diagram that the higher either of these markers, the greater the risk of exacerbation. The two together have the highest risk. Now, these studies weren't done before an exacerbation. These were done at baseline, meaning these were the patient's chronic state. Patients who have chronic inflammatory marker elevations are at increased risk of attacks in the coming year. So let's then look at the limitations of the control-based strategy. In other words, relying on our controller medications to prevent attacks. Well, daily low-dose ICS is more effective than low-dose leukotriene receptor antagonist. In fact, the evidence for LTRAs being effective in reducing exacerbations is rather poor. It's rather better on lung function and symptoms. What about putting up to low-dose LABA ICS, medium-dose ICS? Again, a better effect in reducing exacerbations than at step 2. And of course, in step 4, we have the option of adding other treatments. But an important point to make is that of these treatment options, they differ with respect to their effect in reducing exacerbations and their effect in improving symptom control. And this is an important practical question. It was really shown in the FACET study, which is well known to all of you, that by increasing budesonide from 200 to 800 micrograms twice daily, there was a halving of exacerbation risk. Adding a LABA reduced that risk a little bit in both categories, but the major player there was the presence of the inhaled corticosteroids. Whereas in terms of clinical control or episode-free days, you can see that increasing the dose of steroid did very little to improving episode-free days. Adding a LABA was much more effective. So that's one of the reasons whenever we talk about controller therapy is to ask what is its dominant place. Is it going to help you in exacerbation reduction or in symptom control? In the GOLD study, we were able to examine both those because, as you know, we compared using an ICS or adding a LABA. And in terms of the risk of exacerbation exacerbations, you can see that if patients are controlled, well controlled, or total control, they had very similar exacerbation risk, regardless of which treatment they were on. So what are we saying? If a treatment achieves symptom control, it's the level of control that determines future risk. But unfortunately, if the patient stays uncontrolled, then the addition of the LABA becomes particularly significant and it reduces exacerbation risk. So the guidelines are quite correct. They recommend that you add a LABA to further reduce exacerbation risk. So we go from low dose to medium dose to high dose of steroids, but adding a LABA adds symptom control and further reduction in exacerbation risk. Now, it's often said that, well, what about the so-called maintenance and reliever therapy? How good is that at achieving control? And I show this slide to remind people that it's maintenance and reliever therapy. The maintenance part is the same. And so it doesn't matter whether you're using a fixed dose of budesonide formoterol plus Asaba or SMART therapy, the level of symptom control is identical. And these studies included an arm that had serotype. So it's not got to do with the molecules, it's got to do with the limitations in terms of asthma control that we can achieve with the budesonide plus formoterol combination. There's a ceiling of asthma control in patients with asthma. And if one wants further symptom control, one really needs to add a third treatment. I'll come back to maintenance reliever therapy when we talk about exacerbation reduction. But here's a very recent publication, it's still in press, in which we did a formal analysis of patients on different GINA steps to look at the percentage of patients with asthma control who were using either SMART compared to a fixed maintenance dose, whether it was low dose as at least same dose or higher dose, or a high dose of ICS. And you can see that that ceiling is there for whatever treatment you use. It's not because whether it's SMART or not, it's the question of the maintenance treatment. So in this study, the SMART approach was better than high maintenance dose of ICS, but it was the same as ICS LABA fixed dose, whether it was the same dose or a higher dose. So if we're going to step up treatment and add treatments, what are the options? Well, of course, we could add an antimuscarinic. Now, this is antimuscarinics have really gained their place mainly for their effect on exacerbations. And the Primatina study, of course, showed that a further 21% reduction in exacerbation risk in patients who received tiotropium on top of their LABA ICS, high-dose LABA ICS. So if we want to further reduce risk, we can add tiotropium maintenance therapy. And of course, it really illustrates the point that by using combinations, we're exploiting other options for exacerbation reduction, because of course it operates by a different mechanism. The value of adding an antimuscarinic has been shown now in the very latest studies done with triple therapy in asthma. So in these patients, in these studies, and here I'm showing the Trimaran and the Trigger studies published in the Lancet in September. What you see from these bar graphs is the incremental benefit on FEV1, the left-hand graphs, versus exacerbations on the right hand of adding a triple rather than just a LABA ICS. And you can see that for the Trimaran, the exacerbation reduction was not significant. Adding an antimuscarinic, which was in that case with glycopyrronium, did not reduce exacerbations. And in the right-hand graph, you can see that that adding tiotropium had a very similar effect, but it was just significance. It was only a 15% further reduction in exacerbation frequency. So if we're targeting exacerbations, adding an antimuscarinic is an effective strategy. It's not been effective in all the studies, but it is an option that is open to us. I'm not going to talk about biologicals because you're going to talk about them later, but I want to remind you that the whole rationale for biologicals is their effect on exacerbations. That's where the most significant benefit is seen. Not just 21% or 15%, but in fact nearer 50% and sometimes even 70% in highly selected groups of patients. So biologicals are a highly effective way of preventing exacerbations. The amount of symptom control obtained is rather less. So for me, the real issue around exacerbations is what should we be doing in terms of early intervention? If we're not going to rely totally on a maintenance dose, what we would call a control-based strategy for preventing exacerbations, what about early intervention when patients start worsening, when we have the opportunity to intervene? And that really brings us to the discussion of what about the reliever and have we got an option? And for me, it really comes down to the fact that when patients develop an asthma attack, there is warning that they're starting to fall. And what do we do as an asthma safety net? Yes, they may be on all their maintenance treatment. What do we do to catch them when they're falling? And I think that's where a lot of the advances in our understanding of exacerbations is developed. And for me, this really came to light with this study, which looked in detail using electronic monitoring, where we could see what patients actually do before they come to hospital. And in this study, we can see what happens in the 2 weeks, the critical 2 weeks before a patient develops a full attack and has to come to the doctor. Now, in this study, the patients were on budesonide formoterol maintenance, 2 puffs twice daily. That's the black line. And you can see they were meant to be taking 4 puffs a day. And you can see the blue line is their use of SABA, of a short-acting beta agonist, in that critical 2 weeks when the asthma was worsening. And there are 3 points that come from this. The first is the excessive use of SABA. Those blue dotted lines, some patients were taking 52 puffs of their SABA, of their salbutamol per day for days before coming to emergency room. Secondly, they were taking SABAs very regularly during that period, and we'll produce some evidence for you that that regular use might actually have been making their asthma worse. But the one that really worries me is that there is no safety net. These patients were doing what the doctor asked them to do. They were taking their SABA as needed. They were taking their Ventolin as needed. And they were hanging on, hoping to get better. And of course, they only got worse. Now, that is the period during which patients die of their asthma, while they're waiting at home, waiting for their SABA to work, which of course it often doesn't do. So there's really no safety net. And I think this is what we need to address when we, as part of our strategy of early intervention for exacerbations. And we'll talk a bit about that in the next talk. So to conclude this talk then, asthma attacks are common, even in mild asthma. They occur even when symptoms are controlled. They're associated with both short-term and long-term consequences. We cannot predict the risk of exacerbations accurately. It does help to identify the patient with higher risk because, of course, we would use higher maintenance treatment for them. But that does not, it reduces but does not remove their risk. There's an over-reliance and overuse of SABAs, and that's still a major cause of morbidity. Maintenance treatments reduces the risk, and that treatments vary in their ability to prevent asthma attacks. And treatments may prevent exacerbations by more than one measure, meaning a mechanism, for instance, LABA plus ICS, or adding a macrolide, or adding a leukotriene receptor antagonist. So we need to think about that. It's very striking for me that none of the new developments in asthma, including the biologicals, have been tested against the maintenance of reliever approach. And I'm going to talk about that in the next talk. But this early intervention for worsening asthma provides us with an additional option, an additional strategy for preventing asthma attacks. So thank you for your attention in this one. According to your chairman, I think I am due to continue with this second talk. So perhaps I should just do that. I'll switch over to the slides for the second talk. Right, I thought I'd show you a picture of Cape Town, the way it looks today. Nice hot summer's day. Everybody is beginning to take holiday. So I really want to talk about the challenge of early intervention for worsening asthma, which I've already called the asthma safety net. And I thought I'd start with a typical patient, but this happened to be my patient of a few months ago. 61-year-old lady who's got asthma since the age of 4. She has got quite good effort tolerance, and you can see her spirometry was within normal limits. It wasn't less than 80% predicted, and she showed reversibility when we tested her. She had positive skin prick tests, hay fever. She'd also been a smoker, but clearly is highly atopic. But when I spoke to her about her symptoms, she said, look, I'm okay with my asthma. I don't wake at night, but I cough when I laugh. I'm always a bit chesty, and everybody knows that I'm the one who coughs a lot. I use my reliever whenever I need it. I really don't know, she said. I think probably 3 or 4 times a week. But her partner said, no, you use it almost every day. You don't even know when you're using it. You just do it reflexly. Now she's developing problems because in winter she gets an upper respiratory infection at least once, gets treated with antibiotics on occasion, sometimes with prednisone. And in the last 2 years, she's been in hospital with so-called pneumonia. Now, when I asked her about her medicines, she said, well, I take, she actually takes a Ventolin as needed, but I also take Salmeterol twice daily. And I said, how long have you been on that? And she said, well, for as long as I can remember, more than 15 years. So I said, well, surely your doctor must have given you steroids at some stage. And she said, oh, yes, many years ago, my doctor gave me a brown inhaler and said I must take it twice a day. But you know, I didn't feel any better, so I just stopped it. But I like this one, green one, the Salmeterol. I felt it was doing something. Now, I don't know what you think about that treatment. Clearly, we do not recommend maintenance treatment with Salmeterol because it's associated with asthma deaths. But I think she illustrates a few points. Firstly, she thinks her story is quite benign. She doesn't feel she's got a serious disease. Clearly, she understands that there's risks. She doesn't like what happens in winter. She relies heavily on her SABA, refuses to take inhaled steroids, and she chooses monotherapy with a LABA instead. She's not happy, but she was resigned to her state. This is how I've always been. I'm 61, this is the way I will stay. Well, is that adequate? And what do I offer a patient like this? I think she illustrates the points I really want to make. When we look at patients' preference, they will always stop their maintenance treatment rather than their reliever. And I think this study from Australia was one of the first using electronic monitoring in a clinical trial. It was a 6-month trial when they were meant to be on Seretide 2 puffs twice a day. They all consented to take part. They all promised to be regular with their treatment. But you can see that even at 1 month, only 60% of patients were taking their treatment regularly. By the end of 6 months, only 30% were taking their maintenance treatment regularly. And why is this phenomenon that even patients who we think are good patients will probably use their treatment about 1 day in 3, or maybe 1 day in 2, if we're lucky, and are very unlikely to take it every day? Well, there are several reasons for it. The first is their attitude towards maintenance treatment. And I think this questionnaire done in this particular study was particularly good because the most popular answers were, I manage my asthma myself, I use my medication as and when necessary, I'm confident to intervene, and when I take it, I want immediate relief. That's exactly what my patient said. She said, I don't want that brown inhaler because I don't know that it's doing anything. How do I know it's even working? And that's a common question, and it's quite a reasonable question. So people experiment, they stop and wonder whether they can manage without. And of course, they don't see the exacerbation risk, the risk of an attack immediately. They may not see it for months. They may have just a mild worsening of symptoms. But of course, they are losing the opportunity to prevent exacerbations. But we're responsible as doctors for teaching them this bad habit. Because when they come to us with mild asthma, we give them a salbutamol inhaler. We say, take this reliever as needed. You can take it as many times as you like. Whenever you feel your chest closing up, you take this and it will cause bronchodilation. So we're giving them autonomy. We're saying, you decide how and when to take treatment. But when they become a bit more severe, we try and take over control. It's what the psychologists call the locus of control, shifts from the patient to the doctor. And we try and instruct the patient how and when to treat. And they don't take to this. And so they will, to please us, take it a little bit. They'll take it when they think they need it, and they'll take it before they come to see us. But as soon as they go home, their maintenance treatment will lapse. And so we have a problem with maintenance therapy. If that's our only approach to preventing exacerbations, it's not enough, because it's very much in the hands of the patients. And this study from Australia again, I think is a very good one, telling us what patients actually do. This was a study from general practice looking at patients who were taking any controller medication, that's the green bars, or they were taking only a SABA, the reliever-only ones. And they're plotted here according to asthma control test values. So you know that symptoms were controlled in those with 20 or above. And in those patients, you could say, well, that's fine. If they're controlled, they could just take as needed symptom control. But in reality, there were many patients with terrible control who were still relying as their only treatment on SABA use. And of course, we know this from many studies that there are many patients with even severe asthma who rely entirely on SABA use because they've given up on maintenance use and they're simply not going to take it. Now, our decision to start maintenance therapy is also dependent upon what the patient tells us. The control-driven approach to maintenance treatment is based upon the patient's ability to tell us how symptomatic they are. But patients can't remember how symptomatic they've been. Like my patient, she was saying, well, you know, I'm not too bad. But her partner said, no, you're terrible. Every day you wheeze, you cough. Patients don't remember because it becomes part of their life. So if we rely on that to increase the treatment, we will always underestimate how badly patients are controlled. And this is shown in this study, analysis from the Badger study, comparing values for the ACT, which the doctor scored at the end of every month, with a daily diary card that was filled in real time. So this was looking at the correlation between asthma control days. And the correlation factor, you can see across the one-year study, was about 50%. Patients could not remember all the days that they were uncontrolled. And if it was more than 3 weeks ago, 3 or 4 weeks ago, the correlation fell to as low as 0.3. In other words, 30%. They could not remember. And yet we rely on what patients tell us to decide whether their treatment should increase. So what am I saying? I'm saying that maintenance treatment is important, and we must go on prescribing maintenance treatment, but we must bear in mind that it will underestimate the amount of extra treatment these patients need and also their exacerbation risk. Because we spend very little time with our patients in a year. We're lucky if we spend 1 hour of good quality time. Maybe nurses, our nurse could maybe spend a little more. Pharmacists may spend 2 hours in a year, but the patient lives with their asthma for almost 9,000 hours every year. So they have a very good idea about what their symptoms are in real time. But they have difficulty communicating that effectively to the doctor. So I want to come back then to this slide to say, well, what sort of safety nets can we put in place to prevent patients from dying in these days leading up to a hospitalization or an emergency visit to the doctor? Pointing out that the natural tendency is to use excessive use of SABA or even the regular use of SABA and long delays in seeking help. I think that one of the concerns that we've had certainly within GINA is the fact that there is such a disparity in terms of our ability to stop asthma deaths. At the top of this graph in the Global Asthma Report, you can see there are more and more countries who are achieving asthma deaths of less than 1 per million per year. In other words, we can prevent these deaths. How do we do it? Of course, there are poorer countries with higher death rates, but I've highlighted some here that have good health systems, spending lots of money on health, who have very high death rates still. And so it's not just the healthcare system, it's not just how much money is spent, it's the approach that is taken that is significant. And I remind you that what are the factors associated in one of these countries, the United Kingdom? It's this thing of underuse of controller and overuse of beta-2 agonists. And we've known that for a long time. These epidemiologic studies from the 90s tell us that with each increase in canister use, death rates increase, whereas with increases in inhaled corticosteroid use, death rates fall. And it does not take a lot of ICS canisters per year. Only 3 or 4 canisters per year reduce exacerbations very significant. So inhaled corticosteroids are highly effective, but patients simply don't take them. But it is also possible that SABA use itself is contributing to that risk of death and worsening asthma. And this data goes back 30, 40 years to the epidemics particularly in New Zealand and Australia, which showed that regular beta agonist use actually makes asthma worse. This study, done on only 64 subjects, randomized patients to either regular, that's 4 times a day SABA, or only SABA on demand or as needed, and followed them for a 12-month period. And you can see that at the end of that period, the last 6 months, exacerbation risk was higher in patients with regular SABA. There were more symptoms, lower lung function, and more airway hyperresponsiveness. So I think this suggests that not only is rescue SABA a bad idea, but it actually, when taken regularly, contributes to worsening asthma. A more direct study showing the role of short-acting beta agonists taken regularly is this one that looked at the mechanisms of lung function decline. And you can see that that airway hyperresponsiveness measured with saline or methacholine with placebo is the left-hand bar here. If the patient took regular terbutaline, they got more airway hyperresponsiveness. If they took inhaled steroids, they got less airway hyperresponsiveness. And if they combined the inhaled corticosteroid with the short-acting beta agonist, there was an abrogation, a cancelling out of part of the effects of the regular SABA. And the same was shown for methacholine. Now, that's probably why we went to sleep on the issue over these 30 or 40 days, 40 years. We've said, well, as long as they're getting their inhaled steroids, they're quite safe taking regular SABAs. But of course, that's not the case. That's not the reality. Moreover, in this study, you can see that patients who took regular SABAs within 6 weeks of treatment also had an increase in sputum eosinophils, suggesting that regular terbutaline actually made their asthma worse. And the relationship of deaths to salbutamol use has been studied in quite a lot of detail. You can see here in this study, which is rather macabre, 35 cases of patients who came to emergency room who were not resuscitated, who died. Their blood salbutamol levels were compared with controls who came to the same emergency rooms but survived. And you can see that the concentration of salbutamol was much higher in the patients who died of asthma. So this tells us that patients who die before coming to hospital don't die because they've had too little salbutamol or bronchodilator. They die with too much salbutamol, perhaps not directly caused by the salbutamol, but because they waited too long waiting for the salbutamol to take effect. So what is the approach? Well, in the 2019 GINA report, there's quite a major change suggesting that instead of the time-honored SABA use as needed across all steps, in fact, we should be using as needed low-dose ICS Modrol, certainly in steps 3, 4, and 5. And of course, that has been there for about 10 years. The difference now is it's promoted as the preferred reliever for patients with asthma. And we need to ask ourselves why. And that's because of the additional role of using an ICS-containing reliever, a reliever with an anti-inflammatory property, or what we can call an anti-inflammatory reliever. So if instead we give that during this period of worsening, it will provide a safety net, which is not provided in this setting during the window for an intervention. So I want to talk about safety nets. What options are there? Well, we recommend, and GINA recommends, a written action plan. I mean, the whole point of an action plan is to remind people what to do to recognize and respond to worsening asthma. Then we individualize it and make sure the patient understands it. We try and put them in touch with where they should come when they have an attack. We may give them advice about changing their ICS, and we'll talk about that. And in patients, and only some of them who may be on peak flows measures, we could give them an action plan based on peak flow. But there are only three strategies that are evidence-based and that are contained in GINA, which can be used to reduce, to act as a safety net. The first is quadrupling maintenance dose of ICS. The second is to self-administering high-dose oral corticosteroids. And the third is using the maintenance or anti-inflammatory reliever approach. Now, some of the studies for these different methods are negative and others are positive. The only ones that are reliably positive are the maintenance and reliever approach. And we need to analyze why that's so. So here's the study by McKeever and colleagues published last year in the New England Journal of Medicine, which showed a 19% exacerbation reduction if patients quadrupled their dose of inhaled corticosteroids. This study was done in adults. And so if they were on, for instance, 200 micrograms of budesonide twice a day, they needed to increase it to 800 micrograms twice a day. Of course, they could only do it if they weren't on a LABA ICS and if they had an inhaled steroid to quadruple. The test for children, the childhood test, shows what they call the high dose, which is the quadrupling of the dose, in fact, quintupling of the dose of a steroid versus low dose steroid maintenance using a SABA. And you can see exacerbations here where the symptom scores, the albuterol use was completely unchanged. There was no statistically significant reduction in exacerbation risk. And here is the probability of not having a treatment failure. It was identical. In other words, it was ineffective. Now we need to ask ourselves why that is so. Why are these studies equivocal or only or negative? And that's because it relies on the patient to make quite a difficult assessment, to assess that their asthma symptoms are bad enough for them to have to change their maintenance treatment and increase it 4 times. When I've tried to do it on patients, they often tell me, well, you know, I thought that was quite complicated. I'd rather you make the decision. And of course, you weren't there. So I just stayed on my regular treatment and I just took my SABA. So in these studies, when one looks at how often people actually did their action plan, whether they followed instructions, about half of them do, about half the time. So it's not a highly successful method and it's not intuitive. It doesn't happen automatically. It's a very conscious decision patients need to make. You might have heard me use the term paralysis by analysis. My patient said, well, I tried to analyze it, but it just confused me, so I did nothing. It is complicated for them. So we have the option during that worsening period when inflammatory markers are increased. We have the option for introducing an inhaled corticosteroid as the symptoms increase. And of course, that is the anti-inflammatory reliever concept, that instead of waiting till the patients need oral corticosteroids, we intervene early when symptoms become bothersome. And if it contains a steroid, we prevent the asthma attack. And of course, there's abundant evidence that this is a highly effective approach in milder asthma, step 2, step 3, step 4. You can see the red line shows the reduction in exacerbations in patients over the course of a one-year studies. This is a combined analysis of several maintenance reliever therapy studies showing a very much bigger than 21% reduction. This is a very striking reduction. And I want to come back to the fact of biologics and other treatments that have never been tested against maintenance reliever therapy. So we don't know how many of those patients who have reductions of 30% or 40% with biologics might achieve something similar if they simply used anti-inflammatory reliever rather than relying on a SABA alone. The mechanism of action is quite clear from a number of studies, but here is one that I rather like, showing what happens over 28 days after a patient takes an increase, a reliever. So if they took the left-hand side, if they took two extra puffs, or 4 extra, 6 or 8 extra puffs of reliever on any one day. And you can see, obviously, if they're taking more reliever on any one day, their risk of an exacerbation in the next 4 weeks is much higher. But what this slide shows very clearly is that the bigger the need for inhaler, the higher the dose of reliever taken, the more effective it is if they get an inhaled corticosteroid at the same time. And you can see from this graph, which is the other half of the study I showed earlier about the 2 weeks before an exacerbation, you can see that, that a much more orderly use of inhaled steroids, 4 or 6 puffs a day only, none of them reaching 15, 16 puffs or more. And during the recovery phase, after they'd had their dose of prednisone, you could see that they reduced back to maintenance therapy. So why is it so effective? Well, it's these 3 points. It's 2 drugs, the right drugs, bronchodilator, anti-inflammatory, right time, early, before the inflammation is at its worst, and in the right dose because they titrated against their symptoms, which turns out to be relevant to the amount that they need to control their inflammation. But most important to me is the fact that it fits with normal human behavior. It's intuitive for people to use a reliever. It's logical. If you have a headache, you take a treatment. If it persists, you take a stronger treatment. If you get bronchospasm, you take a bronchodilator. If it persists, you take another dose and another dose. And that's what they do already. Here, at least we're giving them a controller medication to assist them. And so back to the analysis I showed before, what changes is not their day-to-day asthma control. That's the same as they would with their usual.
Actually, we have break for 2 minutes for the doctor, and then we came back to him. Okay? It's not actually a break. He just want to take like 2 minutes to fix something in his presentation, and then we came back to us. Okay, so please, you can be seated until he came back. Okay, thank you very much, ladies and gentlemen.
Can everyone hear us? Hello, testing. Testing 1, 2, 3.
Hi, Dr. Yalla. We are back to you. Okay, thank you very much.
Thank you.
Just a
Yeah,
few
I
seconds.
apologize.
All the doctors will be inside the room. Just give us 1 minute to invite all the
Okay.
doctors to be back. Okay, thank you very much, doctor.
Okay. How long will your power last? On my laptop. It's been charged, so it will last until it last. These three are still there. Well done. Well done. Well done. You're a star. You did it so smartly. Thanks.
Please, doctors, would like to invite you again to complete our presentation with the doctor. So please, you will come back to listen to the doctor again. Thank you very much. Doctor, the live is for you now. You can go.
Can I start?
Yes,
Right.
yes, start, doctor.
I apologize for the break. There was a power issue outside. So I was just describing this study, which really shows quite clearly that patients on maintenance and reliever therapy have fewer days with no treatment and fewer days when they have just one of their two maintenance doses. And the reason is quite clear, because if they develop symptoms on a day when they haven't taken maintenance, effectively they will take it as reliever and get the maintenance at the same time. So it's effective in improving adherence. It's not advancing. And finally, what about the viruses that I spoke about? Is this approach effective in viral-induced exacerbations? Well, this analysis from some of the maintenance and reliever therapy studies, we looked at patients who'd had symptoms of cold before they developed during the clinical trials, and you can see the proportion that went on to develop asthma attacks was greatly diminished by 69% if they were on budesonide maintenance and reliever therapy. So using an ICS-containing treatment during a viral infection reduced the likelihood of that becoming an exacerbation. And I think that's an extremely important point in view of the importance of viruses as an inducer of asthma attacks, particularly in children. And so finally, I'd like to just make a point about that I find very important clinically about using maintenance reliever, or if you like, anti-inflammatory reliever. And that's what I call the continuity of message and the continuity of care. Because effectively you say to a patient on step 3 here, you say to them, you have asthma. It has two components. It's got bronchospasm and there's inflammation. They go together. When you get attacks, it indicates your inflammation is increasing. We give you maintenance treatment, but if when on top of that you're getting symptoms, you need more of the same treatment. And the treatment of asthma is one treatment. It's a combination treatment. We never give you a SABA alone just to treat one component. We give two-component treatment, just like in TB. There's combination treatment. We need 3 drugs to treat TB. We need 2 drugs to treat asthma. You can't treat it with 1 drug. And of course, if they need more treatment, it seems so logical then to just step up the treatment and step down the treatment, but it stays the same. There's continuity of message, and there's continuity of treatment across treatment steps. And today I'm not going to be talking about steps 1 and 2, but you know that that's an active area of very active research where the same message may apply. So my summary and conclusion: asthma deaths and hospitalizations are all preventable. We should have 0 tolerance for asthma deaths and 0 tolerance for attacks, as the Lancet Commission said. But over-reliance on SABAs and underuse of steroids and poor adherence continue to be our major obstacle around the world in achieving asthma control and cause major morbidity. We need to recognize that patients can play a very active role in their chronic disease management. They want to, they are already. They have to live with the disease year-round. They prefer relievers, and SABAs are too easily available. It's an easy cop-out, it's a very easy option, but it's not the right option. Gina now says use a reliever. It should always be accompanied by a dose of ICS, preferably in the same inhaler, to avoid differential use of SABA, because people always will default to the SABA. It improves ICS coverage and adherence. It provides consistent messaging and continuity of care across treatment, and it fits with normal patient desire to be intelligently involved in their disease management. And from a medical perspective, for you and me as physicians, it gives the best protection against asthma exacerbations with very similar symptom control. We haven't had time to talk about severe asthma, but I know that you're going to be talking about it later. But I would be very pleased to take questions now as I've finished my talks. Thank you very much.
Thank you so much, Professor Eric, for this 2 presentations back to back, which is really appreciated. Now the floor is open. We'll take a few questions from here, from Riyadh, and then we'll move to our colleagues in Jeddah and then to Al Khobar for questions. So we'll start from Riyadh here. If there is any question, please just raise your hand, your name and your institution. Yes, go ahead.
Hello, Assalamu alaikum. I am Dr. Muhammad Shahid Akhtar from Riyadh. My question is, you tell about the controlling of asthma, but you didn't tell how to measure to control the asthma if it is if there is exacerbation. How to measure to control the asthma?
To measure control of asthma, is that what you'd like to know?
Yeah, how to measure that it is uncontrolled or controlled, definitely.
Well, we rely mainly on what patients tell us about their asthma. And I showed you the GINA assessment based on 4 criteria: daytime symptoms, nighttime symptoms, beta agonist use, and normal activity. For most patients, particularly if it is mild asthma, that is sufficient. Clearly, we can add to that assessment of lung function, usually just periodically. Those are the standard measures. Now, once one gets to the more severe asthma, there is value in considering using FeNO on on an occasional basis. But that adds complexity and cost to management. So the standard approach is by clinical criteria. I think what we need to recognize, however, is that there are shortcomings of using the GINA system or ACT well, ACT is the one I use, asthma control test. I use that in my clinic. Everybody fills it in when they arrive, which gives us an idea how they've been over the last month. But one still needs to ask questions about their symptoms and then look at their risk.
Oh, okay, another question?
Yes.
Go ahead.
Thank you very much for a brilliant presentation, and definitely it added art to our knowledge. And I'm Dr. Wasif Zamir from Ministry of Health, and I'm working as a family physician in a primary health care. The major challenge which we face right now is switching from a SABA to ICS, because the patient comes with Google search about the use of corticosteroids. So switching them, and their major concern is that what are the side effects with the long-term use of corticosteroids, and the acceptability in the community. Secondly, the patient, which we face a major challenge again, is the follow-up with the patient, because once the patient leaves, we cannot follow with the patient, and this is the major challenge which we face. One thing more, please, regarding the diabetic patients, because is it safe to use ICS for long time, the patients who are diabetic? Thank you very much.
Thank you very much for highlighting those issues. Yes, steroid phobia is a very important thing to tackle. And I think those of us who have been in the game for many, many years, as I have, realize that this is a perennial issue that needs good education. So it starts with us as physicians understanding those risks. And in most instances, so I would really encourage you to read what GINA says about the risk, or look at the SINA guidelines, where it says quite clearly the safety of low-dose inhaled steroids. And remember, the majority of patients with asthma need only low doses. How can we lower those doses? So if I can say to a mother who's concerned about her child, I can say I can lower the dose if I combine it with a LABA, because you don't need as much steroid if you have combination therapy. I could also say to him, we could take it as needed, because it's been shown that as needed use reduces the need for steroids. And I haven't spoken about that. If one uses as needed ICS LABA. But we really need to remind patients that the consequences of badly treated asthma for a child are worse than those for adults. And while we're dealing with the side effects in diabetes, it's only really when one's dealing with high-dose inhaled steroids that it presents a real problem. I mean, you need to remember that diabetics take their treatment according to a treatment in a more steady state. So even if their glycemic control is challenged a little by high-dose steroid, I'm talking about the most severe patients, they're going to be in much more trouble if they need oral steroids. And but they adjust their treatment accordingly. So what I'm saying is, my experience with diabetics is it's no problem at all, particularly if you get them controlled and you get them on the lowest effective dose. It's not a real problem. You mentioned the problem of follow-up. Well, that of course is very much an issue of where you're practicing and your practice context. I appreciate that in primary care that might be difficult. But my approach again is that we've got to develop treatments that give the most effective results, because that's our best chance of patients adhering to it. If we treat patients half-heartedly, they'll go elsewhere for their treatment. For me, the importance is to show them that the treatments we use are effective, and to give them value for their money, and then they will return for follow-up. But I agree that for any chronic disease, it's essential that one is able to follow up one's patients, even if it's only once or twice a year. But a patient who's controlled with asthma often only needs a visit once or twice a year, once you've got them on regular, effective treatment.
Okay, you have a question? Yeah. Yeah, go ahead.
Yes, thank you, Professor, for such. Thank you, Professor, for such thoughtful and condensed presentation. My name is Dr. Sulaiman Ahmed. I'm a pediatric resident in the Prince Mohammed bin Nayef Medical Center, which is affiliated with the Security Force Hospital. My question is technically divided to two sections. Is it absolute contraindication to use the ibuprofen and diclofenac dose, which known as non-steroidal anti-inflammatory drugs in such asthmatic case? Is it absolute contraindication or not? And the other question is, can we have a medical rule for using antihistamines such as chlorpheniramine and dimethyl in the pediatric patient, those who's known as asthmatic, or it's also known as an absolute contraindicated medicine? Thank you.
Thank you. Well, of course, the use of diclofenac or ibuprofen in asthma does present a risk, and many asthma patients will develop acute bronchospasm, even anaphylaxis, and there are many asthma deaths around the world because of that. So in general, it's an absolute contraindication. However, I need to mention that in the literature, there are examples of it being given in a test situation, and even cases where there's been improvement of asthma. And that's got to do with the leukotriene axis. So I think the public health point is that you would not give it unless you supervised it and were sure that you could resuscitate patients. Because you know, I've had many examples of near deaths from using ibuprofen or diclofenac. In terms of the antihistaminics are not contraindicated. If patients need antihistaminics for nasal or other symptoms, they may take them, but they are not effective for the asthma component. So yes, you may use them, but they're not going to improve asthma, but they may, of course, they will help nasal symptoms.
Thank you so much. Any further last question maybe here from Riyadh? Yes, the last question.
Can I talk or just? Okay, thank you very much, Professor Ahmed Saladin, Prince Sultan Military Medical City. Regarding the patients with cough variant asthma, so how this smart approach will work? I mean, do you have a special consideration in such patients, or you just ask them to use it as a maintenance dose rather than MART approach? Thank you.
Thank you. That's a very good question. Look, in my experience, cough variant asthma, you first need to make sure that you're giving adequate asthma treatment, maintenance treatment. And that, of course, is not based only on how much they're coughing, but I would like to know whether they've got lung function changes as well. So peak flow sometimes helps me or a measure of airway hyperresponsiveness. In other words, we need to be sure that the cough is due to uncontrolled asthma and to control the asthma. If one has breakthrough symptoms of cough, when we think asthma is controlled, I think we don't have evidence that using an anti-inflammatory reliever is the optimal treatment. And I think that's a study that still needs to be done. But if it's simply like my patient who says she coughs a lot, the patient I presented to you, she said she coughed a lot. Once she went on to smart treatment, her cough actually disappeared. So although it was a dominant symptom, it did disappear. So it's often a reflection of the level of treatment. But for pure cough variant asthma, I think we need more evidence.
Now we'll move to Jeddah. Dr. Ahmed Al Jahani, he can take over there and receive questions from our colleagues. You have 5 to 7 minutes, Dr. Ahmed. Any question from Jeddah? Dr. Ahmed, are you there?
Dr. Ahmed is not there, not here.
Okay, we can move to Dammam now. Dr. Hatem Qutb is there. He can kindly receive questions from Dammam, and Professor Eric is here to answer.
Thank you. Any question for Dr. Eric? Yes.
Thank you, Professor Eric, for excellent presentation. My question about what you mentioned earlier in the first session, the mortality in mild or what's thought to be mild asthma. What is the factors predicting mortality in patients who might be diagnosed as mild or moderate asthma? How to prevent this mortality in those patients? Thank you.
Yeah, thank you. Very good question. So what I was attempting to say about that is, firstly, in the analysis of asthma deaths, if one looked at those patients who were called mild asthma by their GPs, they often clearly did not have mild asthma. They had uncontrolled asthma and they weren't mild. So, you know, that raises the question, when is a mild patient really mild? And that depends on the doctor being able to take a very careful assessment of how symptomatic they are. That's why I think the approach is not just to ask how often are you having symptoms and night waking and beta agonist, but what is your risk profile? And that chart of modifiable risk factors tells you the patients that you must be careful, more careful about. You must make sure that they're on adequate maintenance therapy. But of course, for the attacks, when they worsen, that's where I think the greatest value of using a LABA ICS as needed is, because if I have a patient who thinks they're fine most of the year and only gets worse when they get a viral infection, in effect, they'll be using very little therapy through the year, very little maintenance therapy for the year. What you should be concerned about is what happens when they get their viral infection. And there, if their reliever contains a maintenance component, then we're covering them for that. And I think that's why the whole strategy from Gina is saying we shouldn't just be handing out symptomatic benefit. We should drugs. We should be handing out drugs that contain an anti-inflammatory together with the reliever. So, you know, we can assess risk, but risk assessment has limitations. But we also need a safety net. We need a safety net that catches them when they do need an intervention.
Thank you. Another question here? Yes.
Thank you very much for this elegant talk. My question is that I just feel that the patients, whatever effort you put on them to educate them about the use of especially the controlled medicines, whether it is alone or in combination, we know that most of the time they are working and the results are very good, and asthma will become most of the time controlled. But the problem, the real problem, I feel that the patient doesn't like to stick to their inhalers. So whatever medicine you give them, controller, they improve, they feel better, then they default not to take their inhalers, and they just either go to reliever medication or go on nothing. They become bad and go back to square one. Whatsoever you have done some of the patients, they listen to you, but I feel a good amount of patients, they don't listen at all, and they don't like these inhalers. And they have the idea that it shouldn't be for life. That's the difficulty. I'm asking, what do you do for that type of patients?
Well, thank you. I think you've given a wonderful analysis of what I was trying to say. I think you've described exactly the way I feel about it and exactly what my experience has been over many years. What do I think needs to be done about it? My view is that you need to put in their hands the treatment that will work best for them if when they wake up to the fact that they need some treatment. You see, to me, the problem is if you have a patient with poor adherence, and when they decide they do need treatment, they take a SABA, they're taking the wrong treatment. They should be receiving something that contains an inhaled corticosteroid. So what do I do for it? For patients with poor adherence, they do much better if they had only one treatment, and that treatment contained a maintenance treatment in it. In other words, a combination. I think that's the ideal solution, because what you describe is so common. My patients do it and they admit it. But if I know that I've sent them home with something that when they take it is going to address their inflammation, I think they're in a better, safer place.
Yes, please.
Oh, now I guess we'll move to Jeddah for the time. Dr. Ahmed Jahani, you have 5 minutes to receive a couple of questions from Jeddah.
Thank you very much. Do we have any questions? We have one here.
Assalamu alaikum. Thanks, Professor. As regard your patient in lecture, 61 years, has uncontrolled asthma, hypereosinophilia. It's better to start from here, from step 3. Yani start ICS lab, then see or follow up the response, or shift from start to add-on therapy, immune therapy. As I know from start, he has hypereosinophilia. Role of immune therapy, yani, just to start from ICS lab and see response, or from start add-on therapy, immune therapy, target therapy, anti-IgE, not understand.
So would
Thank you.
You allow me to rephrase the question? I think she's asking if you would consider starting immunotherapy
Add-on, as
add-on
therapy
from starting
start,
step 3,
or wait to see response first.
That's right.
By immunotherapy, do you mean biologicals, or do you mean anti-allergy immunotherapy?
She meant both immunotherapy and biologics, right?
Yes.
Biologics. Okay. Well, first of all, I think that the proper treatment of asthma begins with the pharmacotherapy, because only in that way will you know how severe the patient is. Because remember, our definition of severity of asthma is defined by the amount of controller therapy which is required to achieve control of their symptoms. So yes, I would start them on ICS or ICS-LABA, maintenance dose, if you like, plus as needed, and then give them a therapeutic trial for 6 weeks or 3 months. I would certainly not start immunotherapy biologics straight away, not only because of the cost, but because one would have no idea, no baseline about if and when one could ever stop them again. So I think you need that. Even if the eosinophils are very high, inhaled steroids will reduce eosinophils quite effectively, but there will be that group that needs to move on to step 5 therapy. But no, I wouldn't start with biologics straight away.
Thank you very much. Any other questions? There's one question at the back. No? No. Yeah, there's one. Okay.
Thank you, sir, for your time. My question is about the use of antibiotics in any case of exacerbation of bronchial asthma. Do you recommend or do you not recommend the use of antibiotic in any patients, or this criteria for the use of antibiotics? Thank you.
Thank you very much. As a rule, antibiotics are not needed and should not be used for exacerbations of asthma. But clearly there are occasions where antibiotics are indicated in their own right. And examples might be if a patient has had influenza, where they may have influenza pneumonia, but they develop asthma as well, or if there's some other reason to give an antibiotic. But no, antimicrobial therapy is not indicated during exacerbations. The exception to that is that chronic macrolide treatment has been shown to be effective in severe asthma as a low-dose maintenance therapy, but it's not given primarily for its antimicrobial effect. It's given for a combination of both its antimicrobial plus its immune modulatory effect. But that's another topic and a different indication.
Maybe I don't think we have more questions, so we're thank you very much. No more questions from Jeddah.
Okay, so no more question, Dr. Ahmed, there in Jeddah?
There is no more questions. Thank you.
Okay, thank you so much. Professor Eric, thank you so much for being with us today for the last 1 hour. It was really a great opportunity to have you, share with you the experience. Thank you so much for the audience here. So now we'll split into, we'll take the break now till 4 p.m. exactly for prayer and just a coffee break. And then we'll come back again at 4, where we'll split into 3 cities. Each city will present alone. So definitely this is a very rich program. Forget this music here. Very rich program, and it's 12-hour CME accredited. Don't forget that tomorrow we'll start at 10:30 with very nice program as well. So you will get the 12-hour for both days. It's not only for 1 day. So we'll split now into 3 groups and we'll have our break. Thank you so much.
Inshallah, we'll have a 20-minute break now, so we can pray and have coffee, and 4 o'clock we'll start our program. Thank you very much.
Laptop هنا. اسبابه وعلاجه، طوارئ، العيادات الخارجيه، اخر المستجدات، كله اليوم وبكره. ان شاء الله اذا سمح الوقت حنلخص.
Good morning, doctor. Can you hear me? Doctor, good morning. Can you hear me?
Yes, I can. Can you hear me very well?
Okay, perfect. Yalla, we're gonna be live in a few seconds, okay, with you. Thank you very much, doctor.
Okay, thank you.
Ahmed.
Bismillah ar-Rahman ar-Rahim. We'll start the second session for this evening. It will be amazing evening, I'm sure. So our speaker is Professor Majdi Idris. He's a well-known adult pulmonologist. He's a figure in the respiratory diseases in Saudi Arabia and regionally, and he's very well a star, by the way. He's talking to us about severe asthma management update 2019, and he's from Jordan now. How's Jordan, Dr. Majdi?
It's very good. I wish you are with me here. It's wonderful weather.
Go ahead.
Thank you. Assalamu alaikum wa rahmatullah. I hope you are hearing me very well. So my talk today, will be about severe asthma guidelines and updated on 2019. So this is my disclaimer. There is nothing in particular to this lecture. So I will start by talking about specific terminologies when it comes to bronchial asthma treatment. And I think the first distinction will be about the differences between asthma severity and asthma control. And it's very important because there is a lot of confusion, I'll say, between these two terminology when it comes to the practice of asthma. However, when you look at asthma severity, it's something built in the patient gene. So it is a genetic, if you like, and it only can be assessed in retrospective way, depends on the level of treatment needed to induce asthma control. So what do we mean by that? To just basically simplify it, we say is that if your asthma can be controlled with one drug or at step 1 or 2, we call that mild asthma. If really asthma control require more than 2 drugs, that is step 3 treatment, we call that moderate asthma. And if asthma control require more than 2 drugs or a step 4 and 5 treatment, we call that severe asthma. Also, we need to make a clear distinction between the 3 terminology that's kind of be used interchangeably. And those are the difference between uncontrolled asthma, difficult to control asthma or to treat asthma, and severe asthma. When we talk about uncontrolled asthma, it simply means that the symptoms of asthma are not well controlled. Now, that does not need to be caused by severe asthma. It could be simply related to that the patient is not using the medication, for example. But it just implies that the symptoms of asthma are not controlled. Talking about difficult to treat asthma, it's a situation where asthma is uncontrolled despite apparent good or appropriate pharmacological treatment. So you are giving your patient the right treatment, but despite that, he is not or she is not well controlled. And difficult to treat asthma should not be confused with difficult asthma patients. And that's very, very important. And finally, when we talk about severe asthma, it means that despite the appropriate pharmacological treatment and correction of other comorbidities, then the asthma is still uncontrolled. So to make it that clear, this is the clear definition of difficult to treat asthma. That is asthma that is either the patient or the clinician finds difficult to manage, that is uncontrolled despite appropriate medical treatment. However, in those patients, you might need to consider a lot of factors that make asthma uncontrolled or difficult to control, not necessarily severe asthma per se. And that's to really clear, for example, poor adherence to treatment, poor inhalers technique, that is not asthma to start with, coexistent factor or coexistence morbidity. While severe asthma is that patients that is already on appropriate treatment and they have a lot of symptoms despite the fact that you are controlling all the comorbidities, all cofactors, you are sure about the diagnosis of bronchial asthma, and despite that, the asthma is not well controlled despite this maximum treatment. But before we go any further, let's make an agreement about what do we mean by asthma control. Is it like to say that the patient is feeling well? Is that enough? That the patient is having normal lung function? Or there is something else? Indeed, there is very specific definition of asthma control. And based on the GINA, in order to call it controlled asthma, you need to control 4 important symptoms: that your patient is not having any trouble or asthma symptoms during daytime. You might allow up to twice a week. The patient has no night symptoms. The patient is not requiring Ventolin. And again, you can allow up to twice per week. And the patient has no limitation with exercise or activities. So if the patient presents with all 4 criteria, negative criteria, that they have no daytime symptoms, no night symptoms, not requiring Ventolin, and they have no limitation of activities, we call that well-controlled asthma. If 1 or 2 of those are not fulfilled, we call that partial controlled. If more than 3 are not fulfilled, we call that uncontrolled asthma. But that by itself is not enough, because we need also to control the future risk. And to a great extent, those are the exacerbation, side effect of the medication, and fixed airflow obstruction. And then we need to look at the factor that might contribute to really poor asthma outcome when it comes to these 3 factors. The main important one is the exacerbation, and there is now clear data to show that there is a clear link between, for example, poor adherence to treatment and exacerbation, exposure to irritant, poor or difficult socioeconomic situation, presence of comorbidities such as rhinitis, poor lung function, or the presence of allergic or eosinophilic asthma. Finally, I would like also to make clear distinction about 3 terminology used when we describe about the disease itself, which is the phenotype, endotypes, and biomarkers. When we talk about the phenotype, it should be, what we mean exactly by that is that it is really specific characteristic of the disease. It could be something like biochemical, physiological, or even behavioral. For example, when we call somebody to have smoking asthmatic or allergic, basically asthma, or obese asthmatic. Those are specific phenotypes for the disease. Endotype is very different. Endotype is a subset, basically subtype of the disease. It's defined by distinct molecular mechanism in that disease itself. For example, in a COPD with alpha-1 antitrypsin deficiency. So this is basically specific endotyping. Biomarker is again very different. It is a defined character that we use to measure sometimes the disease process itself, the response to treatment, or the progression of the disease. In case of asthma, sometimes we use FeNO, for example, as a biomarker for a diagnosis and for treatment response. Similarly, blood eosinophil. So these terminology should be used distinctly between each other. Now, how common is severe asthma? If you look at from at least the GINA basically data, we know that 24% of patients treating for asthma, about 24% of those patients are in step 4 and 5. So by definition, those are the ones who might fulfill the criteria of not mild or moderate asthma, not necessarily severe asthma. However, 17% will have difficult to treat asthma, that they are, despite the fact that they are on appropriate pharmacological treatment, they are not well controlled. And about 3.5 to 4% of the patient fulfill the criteria of severe asthma, that they are, despite the fact that they are on good pharmacological treatment, correction of the exposure, correction of the comorbidities, improving the really education and adherence, despite that they have poor asthma control, and that's up to 3.7 or 4%. How should we manage difficult to treat or severe asthma? If you look at the guidelines, they start by number one, make sure that you have the correct diagnosis. And that requires very characteristic symptoms in addition to physiological measurement of obstructive lung disease, that is abnormal lung function or respirometry, showing clear obstructive pattern. After the diagnosis is confirmed, we go to assess the level of control based on the 4 criteria given by GINA: daytime symptoms, night symptoms, requiring for Ventolin as a PRN or reliever as a PRN, and exercise limitation. But we need always to be sure when we look at the level of control to really correct for the comorbidities or other noises that can affect the level of control, because simply the patient might not be controlled because he is not using the medication, or the adherence is basically bad, or there is a comorbidity, a lot of side effects from the drug. So this is why the patient is not using the medication, depression and anxiety, etc. After that, after we make the diagnosis clear and assess that this asthma is not well controlled, we need to optimize treatment in order to reach the best possible control. And this is give you the 5 steps of treatment that's given by GINA and CINA, starting by step 1 up to step 5. And for the sake of this lecture, we are talking about the patient required step 4 and 5 treatment. Those are who have difficult to control or difficult to treat and severe asthma. And when you look at those patients who have difficult to treat, and then you need to move to step 4 treatment, of course, you need to optimize the dose of the inhaled steroid, sometimes add treatments such as LABA or using the SMART approach, for example. Consider non-biological drugs such as LAMA, anticholinergic, or leukotriene modifiers. But also sometimes at this stage, we have to look at the non-pharmacological basically factors that might be important in the uncontrolled status of the patient, such as poor asthma education, comorbidity, and correction of some behavior such as a smoker or weight loss. Once that has been optimized, the patient should be reviewed clearly for 3 to 6 months to ensure that the asthma is well controlled. And in this situation, we always need to ask ourselves, is asthma still uncontrolled after we optimized treatment to really step 4 or 5? If the answer is yes, then this patient fulfilled the criteria of severe asthma, and they should be referred to severe asthma specialist. If the patient is controlled on step 4 or 5 for 3 to 6 months, it's about time to start stepping down the treatment. But if the patient loses the control, if you step down the treatment, that's another definition of really severe asthma. Then the patient need to restore the previous dosing and again refer to basically specialist. At that stage, when we call that severe asthma, then the patient would be evaluated for severe asthma phenotype. And in that way, we do 2 main processes, if you like. The first process to assess that phenotype by looking for a blood eosinophil, FeNO level, if that's available in your hospital, sputum eosinophil, which is not widely available but can be used sometimes, clinical allergic, basically allergic-driven asthma symptoms, and need for maintenance dose or long-term dose of the oral steroid. The investigation that we usually do, we do for CBC and differential, reactive protein, sometimes immunoglobulin, CT chest looking for any different cause than basically asthma, looking for DLCO, of course, skin testing and rasting for allergic asthma, sometimes ANCA for certain diseases such as Cherry-Strauss, and CT sinuses for nasal polyposis and sinusitis. When we know that when we come to that level and we start talking about severe asthma, there's 2 main patterns that we need to basically recognize. Those who have an allergic eosinophilic asthma, or those who have eosinophilic non-allergic asthma. And those kind of have different mechanism. Those who have allergic eosinophilic asthma, usually the disease is triggered by an allergen, such as pollen or dust mite or certain insects, trees, grass, etc. And that stimulates a cascade of event start by the dendritic basically cells that receive this basically allergen, and then stimulate the Th2 basically cells to start a cascade, further cascading of inflammatory process. And there is 3 or 4 basically mediators that can be released by that event to stimulate the allergic asthma, either through the basically IL-5 to recruit eosinophil, or IL-4, IL-13 to basically stimulate B cells to start forming basic immunoglobulin G that's in the presence of the IL-9, start to recruit mast cells and start the allergic asthma component. IL-13 also can stimulate smooth muscle proliferation and stimulation of the goblet cells for more secretions. However, eosinophilic stimulation or recruitment can also happen through the non-allergic basically pathway. It could be by smoking, by pollution, by microbes, viral, or so on. And that again lead to stimulation of a certain cascade of basically event through the ILC2 cells to form IL-5 to produce eosinophil. So in that way, eosinophil can be produced by either the allergic pathway or non-allergic pathway. What really means that if you have high eosinophil in the blood, that's not enough to call that allergic or the Th2 pathway. However, we have a third now recognized pathway, which we call the neutrophilic non-eosinophilic inflammation. And that's again stimulated by a recruitment of the IL-17. And that lead to activation of the CXCL8 basically pathway to recruit neutrophil. Now, this is important because now we have a specific treatment for that drug that I'm going to talk about, either basically azithromycin, or now we might have very soon some specific basically anti-CXCL8 basically agent. So these are the 5 basically status that we now look at when we deal with severe asthma. Those who have 3 of them, which is the red one here, could be caused by basically the allergic basically pathway, which is allergic eosinophilic asthma, non-allergic pathway asthma, or allergic non-eosinophilic asthma. The two blue ones are those who have neutrophilic asthma or those who have very little inflammation, non-inflammatory, or what we call the pauci-inflammatory, basically asthma. The available treatment for those specific severe asthma phenotypes, we have now the anti-IgE. That is basically when we look at those patients who have an evidence of allergic process, that's usually detected by either skin testing or RAS looking for a specific IgE. In addition to the total serum IgE level and body weight, that's not important for the allergic mechanism, but it's important for dosing, plus the presence of exacerbation. So if you have this phenotype, then anti-IgE is probably the right way to go. If you don't have that, you have to look for the other phenotypes, those who could be treated by an anti-eosinophil, anti-IL-5, anti-IL-5R, basically receptor pathway. And this phenotype, they have frequent exacerbation in the last year, plus high blood eosinophil level. Anything more than 150 or 300 might be really enough to call that eosinophilic asthma. And then we have the anti-IL-4R pathway, those patients who again have exacerbation, they have high eosinophil or high FeNO, eosinophil more than 150 or FeNO more than 25. Also in this phenotype are those patients who require long-term oral steroid. Now there is specific factor that can predict the good outcome of the treatment in those specific phenotypes. For example, when you look to the anti-IgE basically phenotype, those patients who have a quite high blood eosinophil, more than 260, can predict a good outcome. Childhood asthma or really allergic-driven symptoms might also predict good response to treatment. Those who require IL-5, IL-5R treatment, and then the higher the eosinophil count, the better the response. More exacerbation in the last year, the better basically the response. The presence of nasal polyposis and the adult onset asthma can predict a good treatment response. The IL-4 basically antagonists are those patients again who have high eosinophil or high basically frequent exacerbation, but also in this patient who have atopic dermatitis and nasal polyposis. And then once we make up our mind, we start the treatment based on that basically specific phenotypes, we really evaluate again. So we look at if there is a good response, yes, then we can continue. If there is equivocal response, we might extend the trial to 6 to 12 months. And if there is no good response, it might be about time to shift from one pathway to another. For example, we have some time that we shift from basically anti-IgE to anti-eosinophil, especially if you have a phenotype that has both of them. Looking at quickly for the data, this is the data using omalizumab, the anti-IgE in those patients who have allergic asthma, and in 2 randomized controlled trials showed that this was very effective in those patients and reducing the exacerbation and hospitalization. Anti-IL-5, the mepolizumab used to decrease exacerbation significantly, and anti-IL-5 receptors again improve both exacerbation and steroid dose. Similarly, in the anti-IL-4 basically efficacy. Basically macrolides are now used for non-eosinophilic asthma, and the angioplasty is used for those patients who have basically PAUSI or non-inflammatory, and the data now is supported in that way. So my take-home message to you, ladies and gentlemen, is like this: asthma control is the goal of therapy, not asthma severity. And asthma control is a complex measure that has something to do with the current symptoms and the future risk. Uncontrolled, difficult to control asthma should not be used interchangeably. So difficult to control asthma, different than severe asthma, different than uncontrolled asthma. Now we have specific phenotypes for severe asthma. Those who have eosinophilic versus non-eosinophilic, allergic versus non-allergic, and those who have inflammatory versus non-inflammatory asthma. And the biological therapy has evolved in severe asthma management, and they are currently the standard of care. Thank you very much for your attention.
Hello. Thank you so much,
Yes.
Dr. Majdi. Finishing on time. We have a couple of minutes. If we can receive some questions, please.
Excellent presentation. Very small question regarding the use of Zithromax to prevent the exacerbation of the severe asthma. I don't know what is the protocol, how you go with that, which dose and how frequent you use Zithromax to prevent the exacerbations of asthma.
Yeah, the dose that is being now recognized is 250 milligram of azithromycin every other day or daily. There is two different way of doing it, but you have to go for at least 3 to 6 months. So you need to extend treatment for longer treatment. So this dose is not an antimicrobial dose. This is an immune modulator dose to really decrease the influx of a neutrophil to the lung. So the dose we are using is 250 every other day for the 3 to 6 months.
Thank you.
Thank you.
Hello, sir. I am Dr. Mohammad Shahid Akhtar from Riyadh. My question is, what are the parameters that you say that asthma is controlled or whether it is not controlled? What are the parameters exactly you can say that it is controlled or uncontrolled exactly?
Thank you. I mean, looking at the SINA guidelines and also GINA guidelines, there is two ways to assess asthma control, is either to use a questionnaire such as the asthma control questionnaire, looking for the score, and that's basically simple 5 questions that the patient need to answer. And if you get score more than 19 or 20, then you are well controlled, basically patient. Or you look at the GINA symptom scoring, that basically you look for the 4 symptoms that we talked about, that there is no daytime symptoms, no night symptoms, not requiring Ventolin, and no exercise limitation, plus the fact that there is no exacerbation in the last year and no side effect of the medication. So you can either use this or use just the questionnaire, the asthma control questionnaire, as it is really endorsed by SINA.
Okay, another question, the last one, please. Okay, so seems to be there is no question. Thank you so much, Dr. Majdi, for your time and for your presentation. Great, as usual. Thank you. So we will move to the next speaker. Our next speaker is Dr. Noha Rajhi. She is a consultant pulmonologist and ILD specialist from King Khalid University Hospital. She is assistant professor, College of Medicine, King Saud University, and she's program director for the fellowship training program. Dr. Noha, she will talk about best of ATM and ERJ interventional science in asthma. Good luck, doctor.
Everyone, I have the pleasure to be here with you all and to share with you what we learned so far from previous research and to translate it in Okay. So how can I go? لا خلاص. So that's not mine. هذا is not mine. That's not mine. Sorry?
Just waiting for the slides to be uploaded. So let's, if you have questions, we can answer, or probably I will ask you a few questions. How many of you are pediatricians? Because the next two presentation will be pediatricians. And one of my colleagues, he said, why always we keep the pediatric topics at the end? So how many pediatricians we have? Just by raising hand? Few. How many of you are family physicians? MashaAllah, good. I think this is one of the aim of this meetings to have, I call them the first liner or the recruiters, because we believe that asthmatic patients, usually they come from the first liner or the recruiters for those patients. So this is good to have. So how many of you are adult physicians? I mean, not family physicians. So we have, okay, that's good. So I think having pediatric and adult topics together, at least to show the major difference between adult asthma and pediatric asthma, and also to help our colleagues who are dealing with asthmatic in general, like family physicians, to know that these clinical differences and the approach, as well as the modality of therapies that are available, which we believe sometimes they are quite different. Dealing with child is totally different dealing with adult patients. Usually the adult patients, they are expressing and they coming to tell you there are problems, while pediatric patients, they don't express, they only cry. So it's a magic that how to diagnose them and how to treat them. Are okay? Okay, so good luck, Dr. Anna.
So we are back then. Today I'll shed the light with you to the updated advances in understanding asthma molecular pathway and its implication in clinical studies, as well as brainstorming of the future coming studies. So over decades, understanding of asthma pathophysiology have been progressed so rapidly. So in order to understand how many types of asthma, or what we call it now, phenotyping of asthma, and as Dr. Majdi Idris highlighted it nicely, we can divide it into two broad categories, T high and T low, and that was according to the signaling pathway. And from there, it was a significant targeting pathway through these signals, and the first studies was done upon the last signaling pathway, or the last in the cascade, as you can see there. which is omalizumab. Omalizumab now is well known, and it have been with us now for more than 10 years, and it showed continuous efficacy in managing severe asthma who express aneuploidy in addition to that with a high IgE level. And it has been recommended for quite good time in CINA as well as in ATS and ERJ guidelines. Moving forward, over the last 5 or 6 years, new understanding of signaling pathway have been progressed, and scientists started to target the IL-5 and trying to block the eosinophil as a cause of difficult or severe asthma. And in matter of fact, they succeeded so well. And all 3 strategies of IL-5 inhibitors, either an anti-IL-5, i.e. mepolizumab and raclizumab, or IL-5 receptor blocker, which is biralizumab, they all show a continuous efficacy in reducing exacerbation and in reducing oral corticosteroid use. One of the systematic review that's been published